Recreo que tuvimos. Vamos a dar comienzo a las sesiones de la tarde de esta interesante jornada que está dando hermosos frutos de conocimiento, de cordialidad. La coordinadora de la próxima mesa, la doctora Elba López Turconi, va a presentar al panel reactivo y va a dar lugar luego al comienzo de la conferencia. Muchas gracias.
Buenas tardes a todos. En el panel reactivo nos van a acompañar la doctora Marina Ridao. Marina es médica especialista en salud pública, docente de la maestría en salud pública de la Facultad de Medicina de la Universidad de Buenos Aires, es investigadora y se desempeñó en el Ministerio de Salud de la Nación como coordinadora de investigación del programa de redes. Actualmente es miembro del equipo de estadística del Ministerio de Salud del Gobierno de la Ciudad de Buenos Aires. Y el doctor Antonio Galesio. El doctor Galesio es jefe honorario del Servicio de Terapia Intensiva de Adultos del Hospital Italiano de Buenos Aires, es vicepresidente de la Sociedad Argentina para la Calidad en la Atención de Salud, es director del Consejo Académico de la Sociedad Argentina para la Calidad en la Atención de Salud, es especialista en dirección de instituciones de salud, académico correspondiente de la Real Academia de Medicina de Murcia. Invito ahora al doctor Perman para su conferencia Instrumentos para la mejora de la calidad de atención. Doctor. Muchas gracias.
Well, welcome back. I hope this afternoon we'll learn some new things. Today, this lecture, the second lecture, we're going to talk about some of the specific tools that we use for quality improvement. And again, there will be audience participation involved. And I hope my goal is to keep everybody awake after eating the lunch and getting maybe all the blood is going to the gastrointestinal areas. So the learning objectives for this lecture are to describe the systems approach to event analysis in more detail, to go into some of the specific tools that we use, including process mapping, fishbone diagrams, which we saw an example of earlier, the Pareto analysis, I promised we would return to that, driver diagrams, and the 5 whys. And then we're going to demonstrate the root cause analysis process at the end. I will try to talk a little bit faster. After I heard the Spanish speakers, I realized I was speaking way too slowly. So the old way of thinking when an error occurred was that it was due to the ineptitude of the individual. And the approach to it was to in some way punish that person. But the new thinking is that the error is due to a poorly designed system of care. And that's what allows the error to occur. So if we think about the system, we need to improve our culture of safety and encourage reporting, which we talked about earlier, and learning. This is all about learning. That's the total approach I take. Every time we review a case, everybody feels bad, something bad happened to the patient, but we're here to learn. We're here to learn and see if we can do things better to prevent something like this from happening to the next patient. And we have to redesign our systems and processes using human factors, principles, such as standardization, simplification, and the use of constraints or forcing functions. So, again, I apologize. I think what happened is we probably have different versions of PowerPoint. And so when I sent the slides, they're a little bit jumbled. So this gentleman is Professor James Reason, and he developed the system approach to medical error. He said the person approach focuses on errors of individuals, blaming them for forgetfulness, inattention, or moral weakness. But the system approach concentrates on the conditions under which individuals work and tries to build defenses to avert errors or to mitigate their effects. Highly reliable organizations, which have less than their fair share of accidents, recognize that human variability is a force to harness in averting errors, but they work hard to focus that variability and are constantly preoccupied with the possibility of failure. Okay, that's what defines a highly reliable organization. So he invented this thing called the Swiss cheese model, and he wrote a paper, which is a 3-page paper that was published in the New England Journal of Medicine. We should all someday write a paper that's 3 pages long that has as much of an impact as this paper has had on the medical community. And what it says is basically that human error is inevitable. We think we're not going to make mistakes, but we will. Especially in systems that are as complex as healthcare. It's going to happen. But safety failures are almost never caused by isolated errors that are committed by individuals. So he talks about the blunt end and the sharp end, and this is a process, and each of the slices of the Swiss cheese are different parts of that process. And only when all the holes line up just right will that mistake that somebody makes on the blunt end, the red part, get all the way through to where the patient is on the sharp end. Okay? So the way to fix this may be to add in more slices of Swiss cheese to prevent that error from getting through. And that's the Swiss cheese model. Now let's talk a little bit about the specific tools that we can use. And I'll give you examples from studies we've done, some of our results. And hopefully it'll help to explain things. So, for example, this is a process map about looking at the process of preventing hypothermia on babies that get admitted to the neonatal intensive care unit. And this is a process map, just basically breaks every process down into its tiniest little steps so that you know what you're doing along the way, and then you can identify where you think the error occurs. And if you do this, for example, let's say you break it down this way, and then you say, well, let's look at the part where we wrap the baby up in a plastic wrap. Okay? And then you make observations or whatever, and you see, well, people aren't doing that properly. Most of the time, maybe the plastic wrap comes off. So maybe that's where we need to focus our effort. But only by doing this and breaking it down into its most basic components can we learn. There are much more complex process maps, and this is just an example without a specific study, but there are lots of interrelationships between different processes, and that a process step is always in a box that's the shape of a rectangle, and then a diamond shape over here, for example, shows you a decision point. Did you do something yes, or did you do something no? And that's the way that works in a process map. It can get very, very complicated. As a matter of fact, this is one that's called a swim lane process map. So a swim lane is, in a pool when people are doing laps, they're swimming each one in their own lane, right? So these are the different lanes. And this is a discharge of a patient process. So you have the physician part, the nursing part, the discharge advocate part, and the pharmacy part. And really, in this case, they're not intermingling, like I showed you in the last one, where each process was part of another process. This one, everybody's kind of doing their own thing at the same time, but all of these things have to occur in order for the patient to be ready for the discharge. So here was a study we did many years ago. I'm very musical. I appreciate having the 2 pianos up on the stage with me. And so when I do projects, sometimes I pick a title. That's the name of a song. So Baby It's Cold Outside is an old song from the classic American songbook. And this was a study that we designed to reduce admission hypothermia in babies. And here is our dirty laundry. This shows that compared to the Vermont-Oxford Network, between 2006 and 2010, these are the 95% confidence limits, 95 confidence intervals, okay? And this is us. Not looking too good, okay? Overall, about 60% of our babies were coming cold to the NICU, okay? So we needed to fix this problem. Why? Now, this shows it in a graphic form, showing the babies at the various temperatures, less than 34, 34 to 35, and so on. This was the distribution. Why is this important? Well, for every degree centigrade that a baby comes into the NICU cold, the chances of their survival goes down by about 10%. And for each degree centigrade decrease in admission temperature, there's an increased rate of late onset sepsis by 11%, and odds of death were increased by 28%. That's in a study by Abbott Labtook. So this is important. I mean, it changes our ultimate outcomes in a significant way. So what did we do? We did a fishbone diagram to see what the different factors were that were contributing to the babies being cold. We looked at equipment factors, environmental factors, baby factors, and clinician factors. For example, the bed takes time to warm up. That's an equipment factor. The room temp environmental factors, and this was you talk about disagreements between obstetricians and neonatologists. The obstetricians want it ice cold in the delivery room because they've got on all this heavy stuff. We want it warm for the babies. It's a conflict all the time. But, the environmental factor here is the room temperature, for example, or that people are coming out, opening the doors, and you're getting a draft, and that's contributing to why it's getting cold. There are baby factors. We all know the baby factors. The baby's wet, the high surface area, and much of the surface area may be blocked from the heating. If there are too many people, too many sets of hands and equipment on the baby at a time, they're not even really getting the benefit of the warmer. Clinician factors, okay? Lack of physician awareness about the scope of the problem. And equipment factors I already told you. So this sort of breaks it down for you into the various components. And then you can see that there are ones that have heavy marks around them, okay? And they're highlighted, and you can decide which one of these things you think is the most important to solve the problem, and then attack those things. You can't obviously fix all of these things at the same time. So we have another intermezzo now, okay? I want you to take a piece of paper that Norma or somebody is going to distribute. Again, I want you to work in groups of 2 or 3, and I want you to, this is an exercise that you have to use your imagination, okay? Because we didn't really do this study, but we're going to pick one of these quality improvement projects: central line associated bloodstream infections, utilization of breast milk, antibiotic overuse, or unplanned extubation, okay? And create a fishbone diagram with the different factors. You're getting a blank piece of paper with a fishbone on it. Use it, sit there together and brainstorm and think about the things that can cause these problems. Pick one of these ideas and create your own fishbone diagram. And after you do that for the next 5 or 10 minutes, then we'll talk about it. Okay, a couple more minutes. Yeah. 1 minute. Okay, I know that you didn't get that far in the process, but we have a lot of material to go through. So I called in the groups in the front the last time. I'd like to ask, are there any group in the back that would like to tell me which problem you picked and give me an example of a few things that you think contribute to the problem? Is there a group in the back that would like to report? You need the microphone. Okay, thank you.
Hola. Nosotros tomamos las infecciones asociadas a catéter. Bien.
Okay.
Bueno, no sé, como equipamiento se nos mezcló un poquito con el tema de los materiales, pero como equipamiento usamos instrumental. ¿Ok? En cuanto a procesos, colonización de catéter.
Escribí yo. En cuanto a los materiales, todos los elementos de barrera, antisépticos y los catéteres en sí mismos. En cuanto al proceso, todo lo que tiene que ver con la colocación de catéter en sí mismo, con el cuidado de catéteres, con la preparación de medicación y con el lavado de manos, por ejemplo. En cuanto al medio ambiente, esto puede ocurrir en sala de partos, en quirófano o en la unidad de cuidados intensivos en sí mismo. En cuanto a la gente, es todo el recurso humano, enfermeros, médicos, técnicos, mucamas y todos los que atraviesan todos estos lugares. Y en cuanto al manejo, el entrenamiento para la colocación y el cuidado, un programa de vigilancia de infecciones, de control de infecciones y el tablero de resultados, por ejemplo. Todos estos factores se interrelacionan para terminar en lo que podría ser las infecciones asociadas.
Sí.
Excellent. Thank you very much for that. So even though we did this from our imagination, you identified many of factors that are really responsible for these infections. What would happen in real life if you were doing a project like this was you would go and you would observe somebody placing a central line in. And you would observe what they're doing to maintain the line every day. And then you would come up with all these different factors.
Bueno, nosotros abordamos el mismo problema y, diríamos, coincidimos con la mayoría y la unidad donde yo trabajo fue un problema y las soluciones que surgieron fue crear una enfermera link, una enfermera que, diríamos, que estuviera atenta a todo lo que es el cuidado del catéter y tomara registro y se escribieran una guía para cómo cuidar esos catéteres y que estuviera observando la colocación del catéter y nos retaba a los médicos, retaba a sus compañeras de cómo debía ser el campo y cómo debía colocarse. Y con eso pudimos bajar el número de infecciones asociadas al catéter y también, que se habló en las conferencias de la mañana, comunicar al personal cuando nos va bien y cuando nos va mal también, y como parte del compromiso.
Sí, yo tengo dudas si la enfermera Link es indispensable. Creo que sí en la capacitación y control de las cosas, porque después en la Suizo se hizo sin enfermera, empezó la enfermera Link y a los 15 días no sé qué pasó, se enfermó. Y 6 meses no hubo una sola infección asociada a catéter. Vale decir que también que el personal ponga adecuada atención y se concentre en un hecho que es un problema, en sí mismo también puede dar resultados. Yo creo que el orden. Y después la otra cosa que nosotros señalamos es tener escrito cómo tiene que ser el procedimiento y normatizado y tener un checklist que se vaya cumpliendo estrictamente como hacen los aviones, que eso también ayuda porque muchas veces los pasos se saltean o no se siguen adecuadamente.
Well, I hope they don't skip a step when I have to fly home. So the interesting thing about quality improvement is that what works in one unit may not work in another unit. And it's an important point that Louie brought out because in her unit, the link nurse worked. And we're going to talk later, I'll show you results from our project on central line associated bloodstream infections. But in another unit, developing a checklist or some other methodology may be the answer. So let's go back to the babies that were cold. We looked at all these different processes listed here to identify what was causing the problem. And this is a process control chart, which is lecture number 3. We'll talk about this a little bit later. But what this shows is that this is the number of days, this is the admission temperature, and each point on the graph represents 10 patients. And you can see that we got to a point where we were going up and down, up and down, up and down, and then we went up and we stayed. So this is important. This was the result of our study on improving the temperature. And as I mentioned to somebody else earlier, we got a lot better, but everybody else in Vermont-Oxford also got better. So we're still not the best, but we're trying. And here's an example of another type of another fishbone diagram from obstetrics, because I wasn't sure if everybody in the audience was going to be a neonatologist or related to neonatology. And this was giving the immunization to the mother after she delivers, the Tdap immunization. And these were all the factors that contributed to that. Okay, I mentioned earlier the Pareto analysis. So Pareto was an Italian economist, Vilfredo Pareto, and he developed this statistical technique in decision making. It selects the limited number of tasks that produce the most significant overall effects. And it's one of the most commonly and easy to implement methods. It ranks the data in descending order. The total frequency is 100. And you focus your quality improvement efforts on the top 80% of the things that cause the 80% of the problem, which are called the vital few. And then the other 20% are called the useful many. They're not unimportant, but when you're starting a quality improvement project, you need to focus on the most important things. Like we heard about today, some of the changes that were made in some of the different units and nationally that we talked about in terms of public health. What did they do? They went for the low-lying fruit, we call it, the things that were easier to grab onto and fix right away. That's where they focused their initial efforts. So this is just an example of a Pareto chart, and what you do is you see here that this is the 80% mark. So if you looked at this particular thing, which has, this example has nothing to do with medicine, but these two bars here, the first two, make up 80% right there. Okay, so you would do your quality improvement project based on those two factors. This is one that was published a few years ago. They looked at improving immunization rates, and again, 80%, you can see in this particular case, 80% was just the first factor alone, that the high risk for contracting the disease was not properly identified. So really their whole effort of their project was based on that. Or in an outpatient setting, I don't know if any of you do outpatient medicine also, but reasons that patients cancel cancel appointments, and these are the various reasons, okay? So if you look for the 80% rule here, okay, it's right around here. So you would look at the patient being sick, you can't do much about that. The parent canceled, no reason given, the doctor requested it, so you would focus your improvement efforts on those things. Okay, here's the next tool. The next tool is called a driver diagram. And what that does, it's a structured logic chart which has 3 or more levels, including a goal, which is the aim or the outcome of your study. The high-level factors that need to be influenced, those are called the primary drivers. And then the specific projects and activities that will affect these factors, and those are called the secondary drivers. So there's an example of it at the bottom, but I have another example that's easier for you to read. Okay, so this is what it looks like. This is your primary aim. Your aim, these are your primary drivers, and these are your secondary drivers. So how does that help? So it helps you organize. So this one, it's interesting because I'm going to talk about a problem that you don't have here because I discussed it with Nestor the other day. So we have a huge problem with neonatal abstinence syndrome. This is from mothers who are using opiates or opioids. Why do we have this problem? When I started in medicine 35 years ago, the mothers who were on opiates were on the street and they were using heroin. Now they look just like me and you. Okay? They started on these medications because they were in a car accident, or they had a dental extraction, or some other thing that people prescribed opiates for their medication, and they got addicted. Okay? This is in part, I blame, and I told Nestor this the other day, I blame the Joint Commission because they told us we had to treat every bit of pain in a patient. They made pain the 5th vital sign. And that's not a joke. That's what they said. Pain is the 5th vital sign. And so mothers got on these medications. They couldn't get off. Somebody said to them, I'm not going to write you any more pills. You need to just stop taking this. So they went to the street. And on the street, it cost them, let's say, $20 to buy a pill to take because of their addiction. But it only cost them $5 to buy a bag of heroin. It was much cheaper. So then they start using heroin. We have in my hospital, which is in a suburban area with a high level of, income, state of living, we have a whole separate unit for babies who are undergoing neonatal abstinence. We used to keep them in the NICU. That really wasn't the best environment for them. So now we have them in a separate unit. And my wife, who's here today, who's sitting in the back, she's a nurse, but she volunteers once a week, and she goes and she just holds the babies whose mothers a lot of times are not there. She just holds them and keeps them calm because that's what they need. Okay? So this is a driver diagram. I needed to explain all that because of the driver diagram. This is a driver diagram looking at neonatal abstinence. So this was an actual study that was done by increasing the involvement of the parents and changing the treatment protocol for infants born with NAS. We would like to reduce the length of stay by 10%. Okay, what were the key drivers? Attaining high reliability in NAS scoring. So there's a scoring system that was invented a long time ago that we still use to score these babies to see when they need more medication, less medication. Okay, but we need to make sure that people are doing the scoring reliably. Optimizing non-pharmacologic treatments, like people holding the babies or wrapping them tight in blankets or things like that calm them down. Standardizing the protocol, so standardizing it for increasing or decreasing the dosage. And improving parental involvement. And so those are the key drivers, and then you develop specific strategies. All NAS quality care team nurse members will go through a scoring training video and achieve a 90% reliability. That's the strategy. So this is the way to organize your quality improvement project. That's another thing, the driver diagram. Very helpful, and either that or the fishbone, really helps you to organize your thoughts about what's causing a problem. Here's Another one, this was an obstetrical example, women increased the percentage of women with a sexually transmitted infection who are notified of their results within 7 days. Again, your key drivers, your design changes. Same idea. And this was one that we developed for a study that we did on unplanned extubation. So we wanted to reduce unplanned extubation in the NICU from 3.6 unplanned extubations per 100 ventilator days to less than 1. And the key drivers were the method for securing the tube, the standard ventilator setup, where was the ventilator set up relative to the baby, standardized the care of the ventilated baby, increased communication, awareness, and spreading of the safety culture, and then specific interventions. And we came pretty close to achieving our goal. We got very close to 1 per 100 ventilator days in this particular study. The 5 whys. So this is going to get us into the next discussion, which is like doing a root cause analysis about a particular problem and why we can't assume that we know why something's happening. So this is supposed to be a true story. I don't know if it really is or not, but here's the story. So the Jefferson Memorial, which is in Washington, D.C., which you see there, it looks very pretty, it was deteriorating. Why was it the granite, which is the stone it was made out of, was deteriorating? Why was it deteriorating? Because they were washing it every day with harsh chemicals. Why were they washing it with harsh chemicals? They were washing it with harsh chemicals to get rid of the pigeon droppings. Well, why were there pigeon droppings all over there? Because pigeons were coming there to eat. There were a lot of spiders, and the spiders, the pigeons were coming to eat the spiders. Well, why were there so many spiders? There were so many spiders because there were gnats, which are tiny little insects smaller than mosquitoes. Okay, the spiders were there to eat the gnats. Well, why were there so many gnats? Because the gnats were attracted to the light. Okay, so when it got to be dusk, they turned the lights on to make the monument look very pretty. The gnats came, and that started the whole cascade of events. Okay, so what did they do to solve the problem? They didn't turn the lights on right away when it got dark. So the gnats went to other places where there were lights and stayed away from the monument. And they solved the problem. They didn't have to keep washing it, and it wasn't deteriorating anymore. So the point of this exercise or this example is to show you, if you had stopped anywhere along this path, if you had stopped asking why, you would have come to the wrong conclusion. And you would have prescribed the wrong solution for the problem. But only by digging deeper and deeper did you learn the true root cause of the event. And I like this cartoon. It says, "It was horrible. She just kept saying why over and over and over." This is Parent Protective Services. So you know that when your kids are a certain age, right? They keep asking why, and then you just finally say, "Because I said so. That's why." So, and curiosity is not just bad for cats. So the next thing we're going to talk about, now that we've talked about getting to the root cause, is how to do a root cause analysis. And I'm going to spend a little bit of time on this. So again, another cartoon. To address this mistake, we must use root cause analysis. I'll begin by saying it's not my fault. So root cause analysis is a retrospective analysis of an event, of information gathered during an investigation. What happened, what normally should happen, what normally happens, and what should happen. And the focus should be on the system and the processes, not on the individuals. It usually requires a multidisciplinary team approach, and it uses a systematic process to identify fundamental cause or causes and associated contributing factors of an event. It helps to identify risk reduction strategies to reduce the risk of future events occurring. When is it performed? Well, we have certain events that are considered sentinel events by the Joint Commission or by the National Quality Forum. And for example, if you perform surgery on the wrong site, okay, so you take out the right kidney and not the left kidney or something like that, that's called a sentinel event. That should never happen. And so in those cases, we are required by the Joint Commission to perform a root cause analysis within 45 business days of the event occurring. So 9 weeks. It's not much time sometimes to figure it all out. So sentinel events and serious safety events are unexpected occurrence involving death or serious physical or psychological injury. Serious injury specifically includes loss of a limb or function. Such events are called sentinel because they signal the need for immediate investigation and response, and we need to complete the investigation in 45 days, which I already told you. What is a root cause? A root cause is the most basic cause that is not, if it was not present, the event would not have occurred. And what is a contributing factor? It's a factor that played a significant role in the event occurring. And if you looked at this information from the Joint Commission from 2015, these are the top 10 reasons why why sentinel events occur, what the root causes were. Some were human factors, some had to do with leadership, communication, assessment. And I have to tell you that I picked up on something that one of the speakers said this morning. We have a very fractionated care system in the United States now. Okay? Doctors who take care of patients in private offices outside, they don't come see patients in the hospital. We have hospitalists that take care of the patients in the hospital. So the doctors in the hospital don't really know the patient. And they work for 12 hours and then they change, and there's another doctor and there's another doctor and another doctor. And then they involve different specialists. Okay? So when I have to evaluate an event like this, it's just mind-boggling how many different people are involved, different teams, the surgical team, the medical team, the specialist, this one, that one, to figure out who knows what's really going on and what sort of communication took place between them. So communication is a huge factor. But this is just a good list of the types of things that were found to be the root causes. And the National Patient Safety Foundation created something called RCA squared, which stands for Root Cause Analysis and Action, and they have a methodology. The methodology here are the objectives for preventing future harm, standardize the root cause analysis process, establish a risk-based system, use a system approach, real action and improvement, and sustainable results. And here it shows the timeline. So we have to do certain things within a certain amount of time. Within 72 hours of the event, we have to triage it. Patient safety and risk management have to see whether this meets the criteria as a sentinel event or not. And then we have the review of the event that takes the next 45 days. We have to implement the strategies. We report this not only back to the Joint Commission, which we're required to, but we have to report it back to the Safety Committee of the Board of Trustees of the hospital. And we usually have a debrief about an event. That usually occurs as close to the time of the event as possible, and it involves the frontline staff. And psychological safety is a very important factor. When people in medicine all come to work every day with the intention of doing their very best. So we need to realize that when a bad thing happens, they already feel badly. And we need to take care of our caregivers. So we actually have a program at my hospital called Care for the Caregiver that provides psychological support to people who are involved in these events. Sometimes we may have to interview people individually, and sometimes they may say things on a one-on-one interview that they wouldn't say in a group setting to figure out what happened with the event. Again, there's team membership, there's a team leader, there's a facilitator who is usually somebody from the patient safety department. Usually try to keep that team small. You do not involve the frontline caregivers in the actual root cause analysis because it'll make them feel bad. So they're part of the debrief where you try to learn what happened exactly from them, and then you move on to the next part of the process and you don't include them in that part of the process. And the purpose of the root cause analysis is, instead of what happened, is to figure out why it happened and how it happened. And you send invitations to the team. You usually limit it to about an hour meeting, and you set an agenda and ground rules, etc. And you have to create a timeline. You review the timeline. You analyze it with the tools, some of the tools that I've already discussed with you today. You find the root cause or root causes and contributing factors. You determine actions that will mitigate the risk of it happening again. And then you try to spread that learning across your system. We have several different ways that we spread the information once we've learned things from a Sentinel event. We have newsletters, we have things on the portal in our hospital that we share the lessons learned at the system level. And you can use a process map. You ask standardized questions. Sample question, was the patient identified properly? Was the information from the various patient assessments shared and used by members of the team, etc.? So these are sort of standardized questions that will help you arrive at the root cause. And then this is something called an event's causal factors, which are the events or the breakdown of the process map you see along the top there. Okay? And then you see below it here what circumstances, states, or events were going on that increased the likelihood of the findings. So I'll show you an example of one. Unfortunately, we had a couple of episodes where babies were given the breast milk from the wrong mother. And this had to do with the storage. I'm seeing some heads shaking in recognition that this problem has occurred here too. Okay, none of us are immune from this. And this was up here. You see the timeline. The mother breastfed, 4-day-old, blah, blah, blah. After feeding, the baby turned fussy, dusky, was moved to the NICU. The bottle was in the refrigerator. The baby was fussy again. They gave the bottle to the father, et cetera, et cetera. And then these are all the things that contributed to it. NICU breast milk process not standardized. Milk not rescanned. So we now have scanners. Like we scan for medications, we have scanners that we use for the breast milk too. And we haven't had another breast milk error since we did this last root cause analysis. So I'm very happy about that. But over the last 5 years, we've probably had 2 or 3 times that something like this occurred. So it's been, I think a year and a half now since we've had an event. So we're happy about that. So human error should never be considered the root cause. And why is that? Because human error is inevitable. And it implies that the event will just happen again if we say that the reason is human error. Well-intentioned, well-trained individuals make errors. Therefore, there must be system factors that assist the error in happening. So look for the system factors that caused the human error to occur. And then each root cause and contributing factor must have an action assigned to it. Brainstorm and refer to what's out there in the literature on best practices to try to figure out how to redesign your process. And the goal is always to make patient care safer. And this is something known as an effectiveness and sustainability chart. And so, you may come up with solutions that are effective but not very easy to do. Okay, you have to assess both the effectiveness and the sustainability of them, and basically you want to have something that's highly effective and highly sustainable, right? You want something that's up in this quadrant here. So after you come up with your solutions, you ought to look at them in that sort of judgmental way. And then this shows you the strength of different types of actions, which I think is really important. So there are weak actions, and I can tell you that so much of the time we talk about education as being the solution to things. We're going to educate the staff more. We're going to educate the doctors more. That's going to make the problem go away. Education is one of the weakest types of actions that we can take to try to improve quality improvement. And we need to do things like the checklist, which Luis mentioned, redundancy or backup systems, increase of staffing, decreasing workload. These are stronger solutions. Okay, the strongest are things up here, like architectural or physical plant changes, new devices with usability testing before purchasing, engineering controls, things of this nature. And they're the hardest things to do. Sometimes they require a lot of money to do them, so it's a problem. But something like a hard stop, for example, I think I mentioned earlier the idea of a strategy that would be a hard stop. That would be like you can't physically click on the discharge the patient order. It won't let you discharge the patient until you've made sure that you've entered all the discharge medications that the patient's going home on. So that's a hard stop. That's a great safety way to fix things. This is not a particularly effective strategy here. This is an infection prevention. The patient in the next bed is highly infectious. Thank God for these curtains. Words of wisdom. If actions resulting from a root cause analysis review are not implemented or are not measured to determine their effectiveness in preventing harm, then the entire root cause analysis activity may have been pointless. So we have to make sure that we really implement the things we say we're going to implement. A lot of times we come up with strategies, we say this is the person who's responsible for implementing that strategy, and then we find out 6 months later it never got done. For example, one of the things with the breast milk that we came up with was not to put the breast milk in the warmer bath. Okay, because that's where the confusion came, where they picked up the nurse picked up the wrong breast milk. Okay, so there are no studies that show that warming the milk up is better for the baby or reduces the incidence of neck or any other complications. So we felt very good about this strategy, and we gave that strategy. The person was responsible was the nurse manager of the neonatal intensive care unit. 6 months later, we had a similar event. It happened when the milk was in the milk bath, was in the warmer bath. Why was the milk in the warmer bath? I thought we decided to do away with that. Oh, the nurses didn't like that idea, so they decided not to do it. But nobody told us that they weren't doing it. They just didn't do it. So you really have to follow through on these things. Now, there's something I should just quickly mention. There's only a couple more things for this talk. One is common cause analysis. And that's really an important thing, because from each root cause analysis, you can learn a little bit about that specific event. But if you group them together and you do what's called a common cause analysis, you can learn a lot more. So common cause analysis from many or all cases of a problem. So I'm doing a common cause analysis right now where we had almost had 5 fires in the operating room over a period of a few years. Nobody got hurt. There wasn't really flames or anything, but there was smoke, and there were drapes that were burned, but the patient didn't get burned. So we're looking at those together to see what we can learn from them collectively. So many or all cases as opposed to the single cases for the root cause analysis. You time or trend them, okay, instead of being directed at the particular event. It's efficient for diagnosing people, leadership, and environmental care causes, and as opposed to a root cause analysis, which is efficient for diagnosing process, protocol, and technology causes. It infers cause and effect using existing analyses. It investigates cause and effect relationships directly, and an effective program of common cause analysis can lower serious patient harm by 50% every 2 years, with 10% of the resource allocation of a root cause analysis, whereas an effective program rate lowers serious harm by 50% every 2 years. So uses much fewer resources. That's the main benefit of the common cause analysis, and you can learn a lot more about things. The last tool I'm going to talk about is something called failure modes and effects analysis. This is really high-level stuff, but I just want to touch on it briefly. This is a chart that we use, and I hopefully have one that's a little bit easier to read. This came from the military and industry in the 1940s. It's a team-based approach, and instead of saying, okay, we had a mistake, we had an error, how did it happen? Failure modes and analysis says, okay, we have a new process or a new piece of equipment or something. Before we start doing it or we start using it, let's figure out what could go wrong prospectively. So you go through this exercise to predict. It's sort of the mirror image of a root cause analysis. It's prospective, not retrospective. And it's new to medicine, but it is being used more and more. And the Joint Commission is requiring that at least one process be looked at with using this tool every year. And it has similar steps to what I've mentioned for root cause analysis. I'll point out that this is from a study that used FMEA to reduce CLABSIs in the NICU. It was published in Pediatrics in 2013. So this is something that has been used, and it has been used in our field. And basically, you score each process or each piece of equipment by about three different things. The probability that the problem is going to happen, which has a scale of 1 to 10. The severity of the problem, like if the problem were to happen, would it cause minor injury or catastrophic injury, again from 1 to 10. And the detectability, how easy is it going to be or how difficult it is going to be to detect the problem. And again, you take those three numbers and you multiply them by each other, and then that creates what's called the risk priority number, the RPN, and that tells you, whether that factor is going to be a major factor in causing a problem moving forward. And this is what the chart looks like. And again, you have the scoring for the severity, the occurrence, and the detection, and then the RPN for each one, for each aspect of a process or each aspect of how a new procedure is being done. So again, from a couple of the experts in quality improvement, Lucian Leap, I had his picture up at the beginning. Incompetent people are at most 1% of the problem. The other 99% are good people trying to do a good job who make simple mistakes, and it's the processes that set them up to make these mistakes. And Edwards Deming, who I showed you at the beginning too, who I said he is often quoted when it comes to quality improvement, he said, a bad system will beat a good person every time. So in summary, most of the problems we have, most errors occur due to the design of the system we work in. There are many tools that are available. I've gone over a number of them with you today, and you've even had some practice with one to help analyze events. And the ultimate goal is to arrive at a root cause or causes of a problem and design effective strategies to prevent further occurrences of the same type of problem. And this is thank you. This is a little small, but I tried to blow it up, and then we didn't even look like people anymore. But there you see Nestor in the middle. There I am with a full head of hair again. Jeffrey Maisels. I don't know where Lewis was. He was probably in the NICU taking care of the babies. Yeah. He was probably the only guy who was working, right? Okay. So
Bueno, vamos a iniciar. Ahora, ahora me parece muy importante. Ahora tenemos a nuestros dos panelistas. No se dedican fundamentalmente a lo que es atención materno infantil. Entonces, el doctor Galesio me parece importante, que trabajó en atención. Estuvimos charlando un poco con él antes, y quería que nos comente cómo fue su visión y su participación en el hospital italiano que acreditó con la Joint Commission y las diferentes barreras o dificultades que tuvo. Doctor.
Sí.
Bueno, como primer elemento coincido en muchas cosas con el doctor Pillman, porque el punto, yo creo, de partida fue comenzar precisamente con denuncia anónima no punitiva de incidentes. De esto tiene una larga historia el hospital italiano, porque comenzó en pediatría por los años 90, después se hizo en varios servicios en forma independiente la denuncia y finalmente lo tomó el hospital. No es fácil, hubo muchas barreras porque durante un periodo de tiempo la cantidad de denuncias que teníamos eran pocas, eran bastante pocas. Probablemente hubo dos factores que tanto en el Hospital Central como en el de San Justo determinaron que empezara a incrementar el sistema y se fuera desarrollando. Uno fue precisamente que tomó la decisión política el hospital de acreditar, y eso significó una fuerza adelante para integrar a todo el personal. Y el segundo fue utilizar el sistema. En el hospital funciona de la siguiente manera: en la web hay un punto donde se puede hacer la denuncia anónima no punitiva, haciendo un clic y con un formulario, y también lo pueden hacer los pacientes y los familiares desde otra pantalla, pero lo pueden hacer. Y a partir de aquí comenzamos con los análisis causa-raíz. Y el análisis causa-raíz sí fue un determinante importante, aparte de la acreditación que obligó a integrar a todo el personal y a entrenar al personal, a todo el recurso humano. Yo en realidad lo llamo capital humano porque también forma parte del conocimiento del recurso humano, es un capital con todo lo que aprende, porque son las horas que utilizamos en entrenamiento y que eso significa un capital realmente desde todo punto de vista. Pero al capital humano se lo integró y empezó a discutir qué eran, es decir, los involucrados en un determinado evento, empezaron a discutir todo lo que significaba el error en los procesos. Es decir, porque efectivamente en el 99% de los casos no es una ineptitud individual, sino que es un problema de sistema. A partir de ahí empezó a integrarse y actualmente hay dos enfermeras que clasifican estos incidentes y si son near miss o casi errores, van de un color, y si son eventos centinela son de otro, y todos los eventos centinela se analizan. Pero se devuelve toda la información, es decir, lo que no se da, la enorme mayoría de las denuncias no tienen una importancia tan grande, pero de cualquier manera se devuelven. Es decir, se pide información a quien es responsable, qué pasó, simplemente. Y después se publican, gran parte se dan a conocer, sobre todo los eventos centinela. Las dos enfermeras están entrenadas en esto y en hacer análisis, el trigger tool análisis. Con esto realmente hemos llegado actualmente, creo, si no me falla la memoria, tú que lo decías hoy, eran 3.000, ¿no? Los anuales, las denuncias. 350 promedio mensual, desde prácticamente 2 o 3 que teníamos mensuales. Hemos llegado a 350 y por lo menos a nivel del Hospital Italiano de San Justo hemos logrado instituir un Ateneo que no es de patología sino de gestión de calidad, al cual tiene una concurrencia regular de 30, 40 personas. Así que esta es un poco la experiencia que nosotros hemos tenido. Creo que el análisis causa-raíz y la denuncia no punitiva con la integración de la gente, sí es un cambio de cultura, pero tarda, tarda y mucho. Tarda y mucho, porque hay muchísima resistencia a este tipo de cambio. Es decir, yo creo que, no sé, pero decime si me equivoco, pero debemos haber tardado 6 años, 7, más o menos, en lograr todo esto. 20 desde que comenzó Seriani.
Hola, sí, el doctor Seriani, que le mando un saludo, se está operando y terminó de operarse hace un par de días y está convaleciente, pero él es el que organizó todo el comité de seguridad desde el departamento de pediatría. 6, 7 años después pasó a ser un comité hospitalario. 5 o 6 años después el hospital tomó la decisión de acreditar para la Joint Commission. Ya se acreditó, se reacreditó 3 años después y creo que continuará reacreditándose, pero es como decía el doctor, un proceso que lleva mucho tiempo, cambiar la cultura. Y otra de las cosas que me parecen fundamentales es que el hospital se dio cuenta de que había que tener por lo menos una pequeña porción de recurso humano abocado solamente a cuestiones de calidad, porque si no antes eran esfuerzos dispersados en los distintos servicios y que cada uno hacía lo que podía o de la mejor manera posible, pero ahora hay 3 enfermeras ahora que están constantemente en el comité, que es calidad y seguridad, es más o menos lo mismo, y algunos médicos incluso 1 o 2 que se encargan todo el tiempo de estar auditando la calidad y la seguridad de los pacientes.
El área de San Justo, somos 2, ahora 5 médicos y una enfermera, pero los médicos no quiere decir que estén dedicados totalmente a esto, 3 de ellos, sino que están como parte de su trabajo.
Sí, buenísimo. Entonces, resumiendo, usted así lo dijo, tiene que ser una decisión política y lleva tiempo, ¿verdad? 2 cosas que son importantes. Se puede
La dirección del hospital, si no, no es posible.
Bueno, muchas gracias. Escuchamos las preguntas del público también, pero sigo así, ¿sí? Le iba a preguntar a Marina, que también estuvimos charlando un ratito en el almuerzo. Marina me comentó que ella se dedica, está en la facultad y se dedicó a implementar la historia clínica electrónica en el gobierno de la ciudad de Buenos Aires. Y bueno, yo también le pregunté de si esta implementación podía ayudar a extraer indicadores para medir lo que se estaba haciendo y también con eso puntualizar si se podía aplicar alguna mejora en la calidad de atención.
Sí, justamente, gracias por la invitación. La exposición me hizo pensar mucho. Yo soy médica, sanitarista y ahora apasionada en la programación. Y con el último modelo de análisis de causa prospectivo, en realidad hacia la búsqueda de la probabilidad de que el evento ocurra y pensando fundamentalmente en evitar que ese evento ocurra, y las nuevas tecnologías y la historia clínica electrónica y los sistemas de soporte a las decisiones en tiempo real. Más que nada lo mío es una pregunta vinculada a si existen, si están usando alguno de esos métodos de toma de decisiones, de soporte a la toma de decisiones en tiempo real para evitar errores humanos, que nosotros en nuestros sistemas todavía, creo que solo el hospital italiano tiene algunas pruebas en algunas especialidades de interacción medicamentosa fundamentalmente. Y bueno, es pensar en si eso se va a desarrollar en algún momento o si la tarea es en muchos casos imposible de anticipar. En el caso de las checklists entiendo que están ayudando a prevenir ese error. Si los sistemas informáticos en muchos momentos están lejos del acto médico, entonces no podría estar interviniendo, o tal vez nos estén filmando lo que vamos a hacer y se van a anticipar a, ojo, no pongas esa cosa de esa forma. Así que bueno, todo esto me hace pensar para dónde va a ir la disciplina y el apoyo de las nuevas tecnologías en el error humano. Así que por eso era más una pregunta que una contar la experiencia.
Well, first of all, I'm so happy to hear about the progress that you're making in terms of implementing electronic health record. I can tell you that this will be a great tool, and you will be ahead of us in the United States because as part of the Affordable Care Act, which became known as Obamacare, hospitals were obligated and doctors' offices were obligated to implement the electronic health record. The problem with the way we did it in the United States was that each hospital and each doctor's office did whichever electronic record it wanted to, and there's very often no interoperability between the different systems, okay? Second thing is we have to take off our hat to IT. We owe them a great deal, and I will say in terms of immediate feedback, we do have what's called clinical decision support that is part of our electronic health record. So if you try to give the patient a medication and it conflicts with another medication, it will stop you from doing that. If you are in the doctor's office, if I go to see my doctor and she hasn't given me my influenza vaccination and she's ready to close the chart and finish the episode of care, something will pop up and remind her that she needs to give me a flu shot. And those types of things do exist within our system. I can tell you one of our biggest challenges is medication reconciliation. I don't know if that's the terminology that you use, but that means that when a patient comes into the hospital, they're already on certain medications. Are you sending them home on the same medications? Have you changed their medications while they're in the hospital? And this can get very confusing and mistakes can happen very easily. So you need to build a very strong system around that. But we do have things that provide immediate feedback to physicians to guide them about the care that they're providing.
Bueno, muchas gracias por la presentación. No sé si te tengo que agradecer por la foto esa donde parecía muy desprolijo. Ok. Espero que esté peinado en la próxima. Yo quería, lo resaltó también el doctor Galesio, pero quiero resaltar el tema de cuánto impacta el sistema en los errores. Son dos pequeñas anécdotas. Una es, en una ocasión fui para apoyar a médicos y enfermeras de un servicio del interior de la provincia de Buenos Aires, una maternidad grande donde había un juicio de mala práctica por una situación que había ocurrido. Había ocurrido que un día, en un sector de la unidad de neonatología de la maternidad, varios chicos empezaron a hacer muchos episodios de apnea que primero se adjudicaron a posible Argentina, poco personal, infección. En realidad, todo empezó en un día, fue muy rápido y eran muchos los chicos que empezaron con apneas en el lugar de chicos en crecimiento y 3 fallecieron. Cuando se estudió qué es lo que había ocurrido y costó mucho trabajo identificar lo que había ocurrido era que había un paciente que tenía una X patología por la que alguien le había indicado morfina oral. La morfina oral se le había administrado por error creyendo que eran calcio, fosfatos, no me acuerdo exactamente qué medicación, y varios chicos que prematuros en periodos de crecimiento habían recibido, calculando las gotas que correspondían, en una dosis monstruosa de morfina oral. No era fácil defender la situación. ¿Qué es lo primero que uno pensaría? Es ¿quién le recetó la morfina oral al otro chico? Después, ¿quién es el estúpido enfermero o la estúpida enfermera que se lo administró? Después, ¿por qué se confundió? Y no, yo quise ayudar a esta gente y me fue bastante bien, principalmente porque pensé en la forma que planteaba Stephen. Pensé en cómo el sistema había perjudicado todo. ¿Por qué se equivocó? Se equivocó porque los frasquitos eran iguales o muy parecidos. Se equivocó porque eran pocas enfermeras y ella le tenía que dar la medicación a un montón de chicos. Y porque eran pocas, era el sistema. Se equivocó porque les pagan un sueldo muy bajo y tenía 2 trabajos. Entonces venía de un trabajo toda la noche y cansada a la mañana se equivocó. Entonces es muy fácil cuando alguien se equivoca señalarlo con el dedo, fue él. Es mucho más difícil darle el espacio que tiene a los errores del sistema y a la falta de chequeos que llevan a este tipo de errores. Y después otro error que recuerdo y que tiene que ver con él. Hace muy poquito vino una empresa a ofrecernos un tipo de tubuladuras y jeringas que solamente se podían colocar para unas sondas de administración enteral, que no se podían enchufar en las vías de administración endovenosa. Y son caras las jeringas que no van. Entonces, no, eso hay que descartarlo. Yo charlé con algunos de los médicos y le dije, ustedes porque son muy inteligentes y siempre se fijan, pero yo que por la facultad me ha tocado ser perito en muchos juicios, yo fui perito en algún juicio en el cual se le había administrado leche por vía endovenosa a un paciente confundido con lípidos. Entonces recordé que cuando recién había vuelto de trabajar en Estados Unidos, en una ocasión me llamaron de un hospital privado, amigos míos, porque tenían un paciente que cada vez que le bajaban la concentración de oxígeno, porque mejoraba, le subía la saturación. En esa época no se medía saturación, se medía PO2 transcutánea, le subía la PO2 transcutánea. Y yo fui inteligentísimo. En 2 segundos me di cuenta de lo que pasaba. Las mangueras estaban cruzadas. Pero mentira que fui inteligentísimo. Me había pasado a mí, en mi propio lugar, con lo cual, ¿por qué me había pasado? Porque en Estados Unidos son todos tan tontos que las mangueras que enchufan en el aire comprimido no se pueden enchufar en el oxígeno. En Argentina ahora tampoco, gracias a Dios, pero cuando nosotros recién empezamos a hacer asistencia respiratoria, las empresas que administraban el oxígeno no ponían todas las rosquitas iguales, porque nosotros igual somos vivos, la verde va en el verde y la amarilla va en el amarillo. Mentira, te equivocás. De manera que todos los elementos que se puedan usar para detectar este tipo de errores los previenen, y creo que todo el sistema, como planteaba Stephen, es lo que debe funcionar para evitar que estos ocurran, y no son solo los individuos que se equivocan con estas cosas.
Well, thank you for making my case stronger. I can tell you that the types of problems you just discussed happen everywhere. There was a milk error at Children's Hospital of Philadelphia, the number 2 children's hospital in the United States, where a patient was given IV milk, intravenous milk, and the patient died. The look-alike, sound-alike medications, that's what we call them, right? The morphine and the other things. We had a similar problem. One night I was on call. This is back a number of years when we took call from home, and the fellow called me and said, I have all these babies who are suddenly having apnea. I had to intubate 4 of them, blah, blah, blah. I just wanted to tell you, we did blood cultures. We started them all on antibiotics. What happened? He figured it out. This fellow figured it out. He sent the hyperalimentation for analysis back to the laboratory. Somebody had switched the bottles of the calcium and the magnesium. Okay, all the babies were hypermagnesiemic, stopped breathing. Okay, so now we pay very, very close attention to medications that look alike. The bottles are similar. They maybe put them in 2 different complete areas of the pharmacy so people don't make these types of mistakes. So again, thank you for what you talked about is called a forced function, where the IV tubing and the oral feeding tubing should not fit on the same type of syringe. That's a forced function. That's a hard stop. It'll prevent the error from happening much better than educating people about that problem. The different types of connections for the oxygen tubing or the compressed air, that prevents that type of error from occurring if you can't physically connect those tubes. So these are very important types of solutions to simple problems that can cause death.
Tengo otra pregunta, si hay un tiempito. Ya hay más preguntas.
Hola. ¿Qué tal? Muchas gracias. Yo quería preguntarle, doctor, en su hospital, si usted tiene gente especialmente entrenada en análisis de eventos, si contrató gente especialmente entrenada en análisis de eventos, o entrenaron gente que ya trabajaba en el hospital, personas de enfermería o médicos, y quería saber también si están usando alguna técnica de análisis de confiabilidad humana.
So to answer your question, I think probably when we started our journey into patient safety, which was a number of years ago, they started by training people who already work there in the methodologies of root cause analysis. And we have a bunch of people who are primarily, their background are in nursing. They trained as nurses, and they have been trained in all different types of quality improvement methods, including root cause analysis, and they are the ones that act as the facilitators when we have these processes. And we have many, many educational programs that people can go through who work for the hospital, doctors, nurses, people in other specialties. We have, I don't know if you have in this country, respiratory therapists. I know in Europe they do not, but we have people who specifically control the ventilators and the oxygen and stuff like that, called respiratory therapists. They also go through this training. They get, we have people that go through the Lean Six Sigma program to learn how to do that. There's yellow belt, green belt, and black belt, kind of like karate, but to learn the methodology of Lean Six Sigma. So yes, we've trained people within, but we've also hired people from the outside. In terms of the last thing you asked me about human reliability, I'm not sure exactly what you mean by this. Certainly high reliability is something that we talk about in terms of a highly reliable organization. Or are you talking about human factors, like the engineering science of human factors? We have one human factors individual who's got his PhD in human factors that works for the hospital. We also have a group of people, a very interesting group of people that work for the hospital now that came from industries, different industries, and they work with us to try to improve our processes. They are paid by the hospital, but their specific job is to look at our care processes and to make them safer.
Yes, in fact, I was talking about human reliability analysis, as they do at nuclear power plants. I was talking about human factors. So,
¿Una pregunta? Quería hacer un comentario y una pregunta acerca de cómo se ha querido igualar la seguridad en la aeronáutica a la seguridad en la salud. James Reason, en el desarrollo de su teoría, propone, y es cierto, que el ser humano inevitablemente va a cometer errores y que por lo tanto, de acuerdo en el libro que él escribe, Human Error, describe cómo es el aprendizaje y cómo uno va automatizando, digamos, el conocimiento que tiene para hacerlo automático. Es un libro realmente impresionante de psicología cognitiva. Ahora bien, en la industria, los puntos de contacto que tiene la aeronáutica, los puntos de contacto que tiene un pasajero, no son más de 5 o 6, y los responsables del vuelo en general son los propios la gente, digamos, los profesionales y técnicos que controlan y que hacen la reparación eventual y mantenimiento técnico del avión. En medicina, desde que uno pide una consulta, y si uno tiene que internarse por una intervención quirúrgica hasta el momento que se va, los puntos de contacto sujetos a error humano son multiplicados al infinito. E intenté buscar en la literatura si había algún estudio sobre los números de contacto y número de errores que se podían tener en una internación. Entonces la pregunta es, ¿qué opina usted si se puede igualar, o no igualar, cómo diferenciamos lo que es la industria aeronáutica, que realmente podría aplicarse al quirófano, por ahí a imágenes y al laboratorio, porque es bastante automatizado el sistema, con respecto a la atención general, y si conoce realmente si hay estudios respecto a número de puntos de contacto y posibilidad de error?
Thank you for that question. I don't know. I can't think of a study off the top of my head that addresses the different points of contact that a patient has. But as I mentioned earlier today, these methods came to us from industry. Industry is different. I mean, engineers, I don't know about you, but when I took care of babies who the parents were engineers, it was the biggest problem I ever had, because they understand only one thing, that you do this and that happens. Okay? So for them to tell them, I'm going to put the baby on the breathing machine and this might happen, that might happen, or maybe something else might happen, this is a difficult concept for them. So I think we can apply the principles that we learn from industry to the processes that we do in medicine. I don't know that we will ever be able to achieve the degree of reliability that they have. I can tell you there is one field of medicine that has succeeded at achieving the 6 sigma level, which is 3.4 errors per million occurrences, and that is anesthesiology. They have reduced their rate of error to the 6 sigma level. So it's possible maybe in some fields of medicine for this to occur, but there are differences between people and airplanes, and we can't deny this.
Yo quería preguntarle, perdón. No, solamente quería preguntarle respecto de los métodos que nos contaba. Por un lado, en los problemas complejos, cómo ponderar, cómo lograr objetividad respecto de los nudos críticos y cuál sería más importante que cuál a la hora de poder elegir en cuál intervenir. O sea, si también hay algún método de ponderación cuando este análisis de causa es a veces difícil de priorizar. Y por otro lado, respecto de estos métodos, ¿cuál le parece más adecuado cuando uno intenta hacerlos en grupo, con perfiles profesionales diferentes? ¿Cuál es más accesible? ¿Cuál es mejor recibido? ¿O cuál es mejor para un equipo heterogéneo en cuanto a su especialidad?
So maybe I can answer that by giving you an example. I did give you the breast milk example where, we came up with a solution and then people didn't want to do it. But when we were doing our unplanned extubation study, the nurses were absolutely convinced that it had to do with the tape that we were using. And we did not identify that through all of the preliminary work that we had done to identify the causes of the problem. It had nothing to do with the tape. But, we live in the real world, and we have to make compromises. So we changed the tape. That's the one thing that's really a beautiful thing about quality improvement, right? As I mentioned, usually you create a bundle of interventions, several things that you're doing at the same time. So we changed the tape and we did these other things, and we saw the improvement. So they felt happy because they thought the improvement was from the tape, and we felt happy because we thought the improvement was from the other changes that we made. So you know, it is a difficult decision to decide what are the most important factors and what do you need to change. But the beautiful thing about the process is that you can make several changes and you can see the improvements that you want to see.
La pregunta era, todos los que trabajamos con gente en formación, hospitales universitarios, hospitales que tienen gente en formación, todos nos preocupa la curva de aprendizaje, la learning curve, de reducirla, de tener sistemas de simulaciones. De todas maneras, es un proceso que hay que pasar. ¿Cuáles son las medidas que se plantean preventivas ante lo que sí es posible que haya errores humanos más frecuentes, que es en los periodos en los cuales, y todos fuimos testigos, Coco, cuando nosotros estábamos con vos en Hershey, que vos eras fellow, la noche que había fellows de guardia que se habían intubar, nosotros nos quedábamos en nuestra casa. La noche que no había fellow y había un residente rotante que sabíamos que no sabíamos, nos quedábamos a dormir en el hospital. Y esta situación nosotros la preveíamos porque sabíamos que le temblaba la mano, que no iban a poder intubar. O sea que siempre el factor que los hospitales pueden tener en cuenta para prevenir errores está en función de todo esto que estamos viendo. ¿Qué pueden decirnos de eso?
Well, I can tell you that, as you probably know, simulation has taken on a very big role in medicine. We have an entire simulation center that is certified, and we have a full-time physician who runs the simulation center and a bunch of people a whole team that works with her. It's absolutely incredible. I mean, you know, we can practice little things with neonatology, putting in umbilical catheters or intubating, but the things that they do for adult medicine, simulating surgery, simulating very complex procedures, the machinery and the computers that we now have to do these things is just, it blows your mind. So I think that's one of the main ways that we can shorten the learning curve, especially nowadays. We don't intubate as many babies anymore, right? We're doing the kinder, gentler form of ventilation. We don't, so the residents who spend less time with us than they used to, we do less intubations in general, so they're not getting the experience at all. We have people coming to fellowship who have never intubated or maybe have only intubated a couple of times. So we have to start at an earlier stage with them. I think that although nothing is as good as the real life situation, that simulation is one of the main ways in which we can, as you called it, you know, shorten the learning curve for various things.
Yo solamente agregar que lo que comentaste de los bundles, que no sé cómo se traduce, el grupo de acciones, paquete de acciones, la importancia que tiene. Y hablaste del tape, y yo me acuerdo cuando yo volví en el año 86 de Hershey, y en el hospital donde entré a trabajar, el Sanatorio Güemes, decían que la única forma que los niños no se extubaran accidentalmente era que les tuvieran la cabeza fija y que no la pudieran mover. Poníamos una banda para sostener la cabeza. A mí me pareció horrible porque en Hershey no se usaba ni en ningún lado en Estados Unidos. Yo la había visto y los chicos no se extubaban. Y entonces hicimos un cálculo de cuántas extubaciones teníamos, diseñamos un estudio aleatorizado, randomizado, y quisimos ver si servía o no servía la banda. Lo que no sirvió fue el estudio. ¿Por qué? Porque el cálculo del tamaño de la muestra que hicimos hablaba de un número de extubaciones accidentales, pero cuando entraron en el estudio y se siguió un protocolo riguroso de cómo se fijaba el tubo endotraqueal, ya no se extubaron ni de un lado ni del otro, lo cual habla que este grupo de cosas es lo que cambia, no es el tape, como dijiste en el estudio tuyo, y no es la banda, como decía yo, lo que evitara las extubaciones. Por otro lado, ya que estoy, digo, a los pacientes les hace muy bien estar en un estudio de investigación con un protocolo riguroso, reciben generalmente mejor cuidado.
Bueno, muchas gracias, doctor Alessio, doctor Ribao, doctor, muchas gracias. ¿Vamos a tomar un café? Gracias.
Bien. Gracias a los perseverantes. Muchas gracias por estar todavía acá. Vamos a dar comienzo a la última conferencia de la tarde. En primer término va a hablar el doctor Stephen Perlman y luego vamos a presentar al panel reactivo para intercambiar algunas preguntas con él. Adelante, Stephen, please.
So, thank you again. I hope maybe you can pretend that I'm a different person so you don't get tired of looking or hearing my voice. I want to thank again everybody who organized this conference today. I'm just totally thrilled with how involved everybody is and how interested they are in quality improvement. It's a great thing because I've been able to share some of my passion with you. I want to thank the ladies in the booth in the back too, who do a fantastic job with the interpretation. And I'll tell you just two things before we get started with this. This is going to be fun. This is about data management and about culture. So it gets very soft science at the end. It's going to be more social science at the end. But I will mention two things. One is that I am an associate editor for the Journal of Perinatology, which I'm sure many of you look at. I am the associate editor for quality improvement. So if you do a good quality improvement study and you want to try to get it published, I highly recommend that you submit it to the Journal of Perinatology, and we would be happy to consider your manuscript. Because not all journals are publishing articles on quality improvement. So we do have a designated section of the journal for that. The other thing I will mention is that Hot Topics meeting in neonatology is coming up in December in Washington, D.C. Some of you may have gone to this meeting before. A few years ago, I became the course director for the quality improvement part of that meeting, which is the first day, the Sunday. And we have a great program lined up this year. I sent the program for the meeting to Norma electronically, and she sent it out to all the people who are participating here. So we would love to see you in the States at Hot Topics meeting, especially the first day at the quality improvement. I care more about that, but I care about the whole meeting. Anyway, so you have the information on that. So let's talk a little bit about how to control your data. And the learning objectives for this session are to describe the commonly used methods to display quality improvement data, to review the management of culture change, and to identify strategies to sustain change. This is also an important aspect. So another quote by Dr. Deming, he said, "You cannot manage what you cannot measure." So it's important that we get the quality metrics, we measure them, and we follow them throughout the course of the improvement study. So I'm first going to share with you a study that we did a number of years ago on reducing central line associated bloodstream infections in our NICU. And this one I'm showing you is an example that we applied traditional statistics to. And again, we did 2 quality improvement cycles. Okay, so the data you see here, the first part is the baseline data. We had 11 infections in 1,000 or so line days for a rate of 10.3. After making a number of quality improvement process changes, which included having a designated team that placed the PICC lines, that maintained the lines and all that, same people, small group of people of nurse practitioners and nurses that did that. Okay, a few other changes in our process. We were able to reduce it from 10.3 to 3.8 infections per 1,000 line days. We made some more changes, which was when the nurses changed over from the hyperal at night to the new bag and everything, they created a sterile field, and they did the changeover on a sterile field, and a few other changes we made. We were able to reduce it to 1.4. Okay, so about a 90% improvement. And we did this, and we looked at it using something called the incidence ratio, IRR, and showed that the p-value was highly significant. So this is traditional statistics. This is what we're all used to, right, from research studies. So I just wanted to start off with that as an example. And by the way, these data are very similar to the study I talked about by Dr. Pronovost in adult ICUs, where he started out with about 10 or 11 infections per 1,000 line days and got it down to somewhere around 1.7. So we had very similar results to that study, which was a very rewarding feeling. But now we're going to talk about how we display data usually in quality improvement studies, and there are two main ways. One is called a run chart, and one is called a process control chart. And they look something like this, and we're going to go into a little bit more detail. So again, this is Dr. Shewart, and I told you that he is the father of statistical quality control, and he invented this chart called the Shewart chart. And the central line is here. Okay, that's usually, well, we're going to talk about the differences between the two types. So measuring change, we're looking for an improvement, and change is in the key data. But it's important that there is natural variation in all processes. So if I took the temperature of everybody in this room, the body temperature, not everybody is going to be 37 degrees centigrade, right? There's going to be some variation. Some people are going to be a little bit lower. Some people are going to be a little bit higher. Every process you measure has a certain amount of natural variation. But if I now gave you all influenza infection, right, then all of a sudden you would see much higher changes in the temperature, right? Or if I changed the temperature in the room, maybe there would be more fluctuation. So this is a difference between the type of variation. So we need the tools to interpret whether the process has caused change versus is it due to the natural variation in the data. And we want to detect it rapidly. So we have these types of charts that do that for us. So again, common cause variation is variation that is inherent as part of the usual process. That's the temperature of everybody in the room right now. Special cause variation is when there's something out there that's causing something to change that in an unnatural way. Okay? And then there's a stable process where there's predictable variation with natural common cause bounds, and there's unstable process where both special and common cause variation and the variation is unpredictable. So we'll show you what that looks like. So this is how long it takes me to get to work every day. Okay? Some days it's less than 30 minutes, some days it's more than 30 minutes. Okay? That's the normal variation. Okay? Now they decide to do construction on the road that I usually take, and I have to go a different way. Or there was a major accident on that day, or something along those lines. So now, instead of the normal amount of time, those few days there, wow, it took me over 50 minutes to get to work. Okay? That is special cause variation. That's not, the common cause variation was the first part, the special cause variation is the second part. You with me, right? Okay. So the value of this, it's incredibly valuable because in the traditional statistics that we talked about earlier that I just showed you about the CLABSI study, you had to wait till the end of the entire study before you could do that statistical analysis, right? That's the way it works with most research studies. But instead, this is displayed over time. Okay? You're watching the value, however you decide what, each patient or each 10 patients, or if it's a temperature that you're measuring, or the use of the percentage of babies getting breast milk, whatever it is, you're measuring it over time. This is visually very important because it engages everybody in your NICU. You can put this graph up somewhere in the NICU, right? Or somewhere where people can see it when they're scrubbing their hands in the morning or something like that, to show them where we're at today. When was the last time we had an infection? How many babies are getting breast milk? Whatever the issue is, it helps to build engagement that you have this visual chart that's in real time. So it's a visual display of data over time. In a run chart, this is called a run chart. It's very simple. The center line is the median. This is the center line, okay? And then you can include annotations, like this is when we made the first change in the process. Things didn't seem to change. This is when we made the second change. Things started to get better after the second change. This is where we made the third change. So you can put annotations on there so people can see that as well. So a run chart is a minimum standard for a QI project. Don't send in a manuscript on a QI project without a run chart at least, if not a process control chart, which I'm going to show you too, which is much more rigorous. You can start plotting the very first few data points. You need at least 10 or more data points to apply the rules that I'm going to show you for detecting special cause variation. They're simple to create. You don't need special software to do this. For the process control charts, you need special software. You can do any kind of data on this. It's very simple. It could be a percentage, it could be an absolute number, anything. But it's not as powerful as a process control chart. This is my favorite paper about process control charts. This paper was written by a guy named Rocco Perla, P-E-R-L-A, if you want to look up the paper, or I can give you the reference. Okay? So here is an example of a process that was subjected to traditional statistics, right? This is the way we would normally look at it. Before we made a change, our number was 70 for whatever it is, how long it took to do something, and now it's 30. And if we look at that, we have a highly statistically significant result. Okay? So that's basic statistics. Now, that looks like we made a change, right? But the three graphs on the right-hand side all represent exactly the same data that's in the graph on the left-hand side. All three. So what does this mean? Okay? This means that in this case, the first case, there was actual improvement. This is where I made a change. We made a change in the process, and you can see, boom, all of a sudden, we're seeing lower numbers. That's a real improvement. That agrees with what you saw here in this bar chart. But look at this one. Same data. This was something that was improving on its own before I even made a change. Okay? And if you interpreted the data with traditional statistics, it would look like you did something. But in fact, you did nothing. It was changing on its own. You see what I mean? Same data. Third one, okay? Data, here's the initial data. We made the change. Oh, it got better. But what it doesn't tell you, the story doesn't tell you, is that it's starting to get worse again. So here, this visual display of the data over time gives you a whole different perspective on what's really going on in your process. And that's what I love about this paper. And here are the rules. There are actual rules that are based in traditional statistical analysis about when a process has changed due to something we've done, or is it just normal common cause variation. If there's a shift from a certain number of data points above the line to a certain number of data points above the line, that means that it has to do with something we did that resulted in change. If we see a trend, a certain number of data points all in the same direction, and I'm not going to go into a lot of detail on this, or all these data points in another direction, this again is an indication of special cause variation. It's something that's changing in the process, either that something that we did or something was changing about a process before we even tried to improve it. Rule number 3 is called the number of runs. That's how many times you cross the median line in the middle. That's also an indication of if there are too few runs. That means that it's not common cause variation anymore. I mean, yes, it's not common cause variation. And this is the last one, which is called an astronomical data point, which means you have only one point that's different, but it's so different from the existing data that you can say this change was due to something we did. Okay? So those are the rules for run charts. Here's data. This is a run chart from the study that we did. I mentioned it, I think, in this morning's lecture. We saw the Vaughan data where we had a problem with pneumothorax. I can tell you, this is a quintessential example of predicting the wrong cause of the problem. We all thought that the cause of the problem had to do with how the babies were being bagged in the delivery room. Everybody was convinced that was the problem. And then we started doing an analysis, and we looked at it, and what it was where we put the initial settings on the ventilator when the baby got to the NICU and was already intubated. Okay, this was a study that was done and published by one of our fellows, and here you go. Okay, here's the rate of pneumothorax before the intervention. This is where the intervention was done, and what happens is not only do we see an improvement, but the mean line here changed from one time period to the second time period. So this is a run chart depicting the incidence of pneumothorax during the 2 periods of the project. The 5 points marked with the triangles and the arrow in period 2 depict a sustained shift in the process toward a lower mean. Okay? And then there's something called the upper control limit and the lower control limit, and I will talk to you a little bit more about that when we talk about process control charts. So here's a real example of a study that we did in our unit to reduce pneumothorax that was highly effective. Now, process control charts are a little bit different because you have a central line and then you have the center line, right? And then you have the upper control limit and the lower control limit. And again, these are based on traditional statistics. The upper and lower limits are 3 sigma away from the center line. And the center line in the process control chart is the mean rather than the median. So it's a simple statistical tool to distinguish between common cause and special cause variation. It consists of 2 parts. The measurements are plotted in time order, and then there are 3 horizontal lines, the central line, the upper control limit, and the lower control limit, and the upper and lower control limits are calculated from inherent variation. Data outside the control limits equals special cause variation. Okay, and again, this is the relationship to probability theory. This is 3 standard deviations in either direction from the mean is what you're looking at when you're looking at those upper control limits and the lower control limits. And here, if you look at it this way, and then you look at the plot, you see that that's where the upper control limit is and that's where the lower control limit. And this is just a process where there was normal cause variation there in the middle, but where we have the red ones above and below, those are special cause variation. And again, I don't want to go into too much detail. These are much more complex than the run charts. Again, they're a visual display over time, so they're very helpful in motivating people. But there are some rules to determine special cause variation. And these are the rules listed here. 1 point outside of the outer control limit. Second one, 2 out of 3 points that are at least 2 standard deviations from the central line. 4 out of 5 points that are more than 1 standard deviation from the center line. These are all the rules. And again, you will have these slides so you can look at it later or you can read up on process control charts on your own. And these are, again, a couple of additional rules for special cause variation. One here, trend of 6 points in a row, increasing or decreasing, and then 14 points in a row, alternating up or down. These are reasons for special cause variation. And just to give you an idea of the complexity, depending upon what type of data you have, is it a discrete data point or is it a continuous variable? Okay, is it a count or is it classification? What are the size of the subgroups? How many groups are there? And these are the different types of process control charts that there are, many different types. So it's not just a single one size fits all like a run chart. This is depending upon the type of data you have, you need to use different things. This was a study that we published this year. We developed a bundle for improvement, or a package, maybe you want to call it in Spanish. And this was we had a problem. We had 5 babies within a period of a couple of years who within the first few hours after birth had sudden unexplained collapse. This was something actually that in the literature most of the studies are done in countries outside of the U.S. Most of the studies I read once I started researching this came from Europe and other places. And what we did was we put together an intervention which included increasing the surveillance by nurses. They had to do an assessment every certain number of hours, and the babies were on continuous pulse oximetry during the first 4 hours, or at least 2 hours after they were born, when they were put on their mother's chest for skin-to-skin care. Okay, again, unintended consequences, right? We started doing all this skin-to-skin care because we wanted to be certified as a baby-friendly hospital, and then we started having this problem. And I can tell you that the results we have not had in now probably 3 years or something like that. We haven't had a single event. And this is a process control chart showing that after the intervention, we saw, this is the number of deliveries. This is the way with the help of a statistician, we learned that we had to do this. The type of chart we needed to use, and we had to do it by the number of deliveries between events. Okay, so this was 5,000 deliveries, and then it went down to, whatever this is here. These are pretty low numbers, probably somewhere around once every 1,000 to 2,000 deliveries. And now we're way up here. This was as of when we published the study, but I can tell you the number's even higher now. We've had no incidents since we did that quality improvement study. And again, this shows a P chart, the percentage of very low birth weight infants with late onset infection. And this is your center line, and this is your upper and lower control limits. Just another example of a process control charts. Okay, so now we're going to talk about change management. We've talked about it a lot already today during the day, like how hard it is to change culture. And I like this quote that I found. Change is hard at the beginning, messy in the middle. That's M-E-S-S-Y, not M-E-S-S-I. Messy in the middle and gorgeous at the end. Okay? So let's talk about change. This is the world according to me. This is my philosophy. And I think it's based on my experience in quality improvement. The reason that most quality improvement initiatives do not succeed is because people don't go through the proper steps of change management. The science may be good, but if you can't get people to follow what you want to accomplish your goal, you are doomed to failure. This is my experience. And you have to get everybody on board, okay? So you have to get nurses and respiratory therapists and and obstetricians and pediatricians and so on and so forth. Everybody at the table at the same time who is involved in the quality improvement effort. Very important. And then when you need to go out and sell your ideas, like you say, we're going to make a change to the process. The nurses are going to have to do this differently. You send the nurse to go talk to the nurses. You don't go talk to the nurses. The doctors are going to have to do this differently. You send the doctor to go talk to the doctors. You send the obstetrician to go talk to them. That's the way you're going to get people to change. So Cotter was a professor at Harvard. He might still be, I don't know. He published this in the Harvard Business Review, his approach to organizational change. I'm going to take you through the steps of his change. He defined the most common reasons that organizational changes fail. He developed strategies to overcome these reasons for failure. It's very applicable to healthcare, and there are 8 stages. Step number 1, create a sense of urgency. This is the most important thing at the beginning, okay? This is called commonly in the literature on change management, it's called the burning platform, right? That's why I put up a picture of a burning platform. It means you get people energized by saying, look, we have an incidence of X% of babies who are having pneumothorax, and everybody else in the Vermont-Oxford Network is doing better than us. We have to do something about this. We have to make change. That's the burning platform. Creating a coalition. This was one of the Italian presidents. I don't remember which one. They change very frequently, right? But he failed because he was unable to build a coalition. So you have to get people who want to be part of the quality improvement project, who will serve as champions for you, who will go out because they really believe in the change and they really think it's important. They will go out and they will sell this idea to their constituents. Oh, another intermezzo. So remember this morning I asked you to pick an idea for a quality improvement project that you thought would be important to do in your area of the hospital. I would now like you to take, we'll just do 5 minutes this time, and think of what you would tell people is the burning platform for that you need to create to motivate people to do this project. Okay, so remember the project that you had earlier and think of a burning platform. You have 5 minutes to discuss it, and then we'll report out. Just a couple more minutes. Okay, thank you. So what we're going to do now is have a couple of groups tell me two pieces of information, what their project was and what the burning platform is that they would create to convince people that this was an important project to do. So is there a group back here that would like to share what they were talking about? Come on, there must be somebody brave enough.
Hola, nosotros habíamos hablado hoy como el tema comunicación, ¿no? O sea, que era una de las cosas más importantes para trabajar en todo aspecto. Muchas veces uno a veces viene el enfermero y te dice, el paciente de 130 tiene fiebre y uno está pensando en el paciente de al lado, entonces le decís, bueno, dale ibuprofeno, 130 miligramos, pensando que es el paciente de 131. El enfermero preguntó por otro y se pesaba 5 kilos, entonces va y le pasa 130 miligramos en vez de 50 y le pasó y le dice a la mamá, le acabo de pasar ibuprofeno porque tenía fiebre. Y la mamá, los papás que muchas veces están atentos a todos. Ay, ¿cuántas gotitas le dio? Tanta. Pero mi hijo usa la mitad. Entonces ya es desde el punto de que se hizo mal la falta de rechequeo, la falta de que el médico muchas veces indica oralmente sin escribir, que el enfermero no rechequea de lo que está hablando. Entonces se arma todo un ovillo y errores que lo vemos diariamente, ¿no? Entonces la importancia de trabajar sobre la comunicación, el feedback entre los colegas y el rechequeo continuo con algo que no necesita más que trabajar en comunicar y que no necesita gastar mucho más dinero, sino en trabajar en eso, ¿no?
So you would tell people, look, we caused harm to this patient, or one patient or the other, or both, by this mistake, and this happened because of bad communication, and this is a problem that we need to fix. How about a group back there on that side? Anybody want to tell us what they were talking about? Maybe they were talking about their weekend. It's going to be a long weekend, I understand. I'm the only thing that's standing between you and your long weekend. Oh my gosh. What were you talking
Bueno,
about?
hablábamos acá con las chicas hablábamos de las extubaciones no programadas, ¿no? Y en nuestra espina de pescado que hicimos hoy a la mañana, teníamos en cuenta desde la falta de checklist, desde la falta de las bundles o paquete de medidas, desde la gestión de llevar un control, porque la seguridad nosotros podemos trabajar con la cultura de la seguridad, pero la cultura de la seguridad no es solamente hablar de lo que nos pasa o reportar, ¿sí? Sino también después hacer controles, trabajar sobre eso, ¿sí? Y hacer entrenamiento. Entonces, cuando hablábamos de la extubación no programada, hablábamos de todas estas cuestiones que nosotros podríamos implementar, ¿no? Y trabajar con el entrenamiento de la gente. Sí, a veces uno piensa en la simulación clínica y piensa que tiene un alto costo, y sin embargo esto se puede hacer con un tubo y con un simulador que está al alcance, nosotros lo tenemos a nuestro servicio, ¿no? Eso, entrenar, hacer práctica deliberada con la gente, ¿no? Un poco eso.
So you would tell them, this is a problem. We have a higher rate of unplanned extubations compared to other NICUs around the country. And this causes harm to our patients because they have to get reintubated. That causes airway damage, etc. And this is why we must do something about this. We must work together to find a solution. So thank you. I'm going to move on to the other slides because, again, I want to get you out of here on time or close to on time. So the step 3 in change management by Dr. Cotter or Professor Cotter was develop a clear vision. link the ideas and the solutions to the overall vision that people can understand and remember. And the reason I have a picture of President Reagan up there is because he was known as the great communicator. He had a way of communicating with people that it was very clear. His vision was made very clear to people. The fourth step is share the vision. So find ambassadors. Okay, that's why I have a picture of the United Nations there. Find ambassadors to go out and keep the vision clear in everyone's mind. So people, again, I said the nurses go out and talk to the nurses. The doctors go out and talk to the doctors. Whoever the people are as part of your working group, they help to keep the vision clear in everyone's mind. Empower people to remove obstacles. This step is necessary to keep everything moving forward. And secure short-term wins, okay? So this is important. You know, you remember when you were in training and they asked you, I'll give you a personal anecdote, but you said, what do you want to do for your research project? I want to find the cure for BPD. That's what I want to do for my project. And your mentor looked at you and said, yeah, right, okay, let's start over. Let's start with something smaller, like maybe controlling the amount of oxygen that babies get or something, you know. So I came up with an idea for a project. This was back in 1984, the year before I met these two Argentine physicians. I was a first-year fellow, and I needed to come up with an idea for a project. And my mentor, Dr. Maisels, was on vacation in South Africa, and I came up with this wonderful idea about measuring T-cell types, subsets in neonates and seeing how it compared to adults and all this. And I did all this background reading and research. And the only problem was that the project was probably like a multi-million-dollar project, okay? It wasn't a bad idea, but it was not going to happen. So he comes back from vacation, and I make an appointment to meet with him. I said, Jeff, I came up with a great idea. He was very nice. He didn't laugh in my face or anything like that, but he redirected me, and I found, so it's important. The short-term wins are important because they, again, build engagement. If you can show a little bit of progress, then more people will get on board with your project, and they'll want to do it. So you don't have to do it all at once. Step number 7, build on the change. So this is a picture on the coastline of New York after Hurricane Sandy. This is what the houses look like. So you can analyze what went well in the first stages of your project and what needs more improvement, and then build on that change and improve things. And then the last step, the 8th step of Cotter, is to anchor the change in your culture. And that means to have it memorialized in some way in either a handbook or a protocol or whatever, so it becomes part of the standard work in your unit. And so here is a list of the barriers and some of the strategies to overcome resistance. The barriers are people have certain habits. They may be in positions of power and influence, and they may not be on board with you. You might have limited resources. We talked a lot about that already today. There may be misunderstandings about what you're trying to achieve. A whole long list of possible barriers to change. What are the strategies to overcome them? Communication, ensuring staffing supports the change, allowing people to participate in the project, promoting perceptions of fairness, negotiation. I told you about the tape and the ET tube, right? That was a negotiation. There are things that you can do to overcome the obstacles and really move things forward. So although all improvement involves change, not all changes are improvement. That's according to the Institute for Healthcare Improvement. So this is Heraclitus of Ephesus. In the 5th century BC, he said, nothing endures but change. So even then he knew, right? A long time ago. But it's difficult to sustain change, because it's hard once you've created that sense of urgency to keep the same level of urgency about it, right? People see things getting better and they kind of drift, right? They go back to maybe doing things the old way. There might be inadequate time to teach staff. And you know, you're always getting new nurses and new residents come every year into the hospital. And so you have new people that you have to educate on a frequent basis. That takes a lot of time. You might not have paid enough attention to the barriers, the things that were preventing you from accomplishing things. And you may not have had the buy-in or the support of the leadership within your organization. Those are reasons. So one of the things that you can do to maintain a sense of urgency is to create competition. Say, you know, the hospital down the street, they have a rate of unplanned extubation that's about half of what we have. Did you know that? Or maybe we could do better than them the next time. Let's try to work on that, okay? Or sometimes it can be within the hospital with certain things in a general. I work in a general hospital. You could say, okay, well, this floor, they didn't have any patients that fell. All right, this is a big problem in the hospital with adults. People fall, okay? They didn't have anybody that fell for a year. We had somebody that fell yesterday. We have to do something about this. Maybe we can learn from them or create some competitiveness between the different units. Always keep the patient as the primary target. And also tell people, you know, it may affect them. If we don't improve, we may, you know, lose the unit, or we may have lose deliveries, or something may change in the environment. So it could affect your job security, it could affect your income, but certainly it will always affect job satisfaction. I mean, people like working in a place where things go well and that people don't have a lot of complications. So Deming said you can't manage what you can't measure. I already mentioned that in an earlier slide. You must do continuous monitoring. Even after your project is over, continue to measure and benchmark your outcomes. Identify reasons if you see that you're starting to slip back. And then maybe do a root cause analysis on the cases that should be on the cases without the desired outcome. Right. So here's a good example of that. This is our data for babies' temperature on admission, okay? And here we were back at the beginning where we were all over the place, but basically running at about 60% at the beginning. And then we made all of our changes and we saw a steady improvement. And then, what happened? We started doing a couple of different things that kind of bumped up against the hypothermia problem. One of them was delayed cord clamping, which meant that the babies were now sitting there for 1 minute while we were not clamping the cord, okay? And we weren't doing a good enough job. We hadn't put in new measures to make sure that they stayed warm during that period of time. So we saw a problem. If we hadn't been continuing to monitor this, look at this. This goes back to 2009. It's up to 2014. We're still following this metric. Okay? We still follow it. But if we hadn't been following it, we wouldn't have noticed that once we started some other things, and there was a BPD bundle that got started around that time too, that might have prolonged the time that babies were actually staying in the delivery room. We saw this bump up. We had to address those things. So continuing to monitor your metrics is important. Sustaining change, sharing the results. We talked about run charts to visually just demonstrate improvement, or telling a story, okay, you know, about a particular patient or a particular situation that you ran into a problem with. Strategic signage, okay, so you can, I saw a unit that had like a ticker tape thing that went across the top, like the New York Stock Exchange, right? But it said the percentage of babies who got breast milk this week, okay, was X percent. Okay, that meant everybody saw that. It gets in their head. It makes them think, I'm going to make sure that this mom wants to breastfeed the next time that issue comes up. So you could have things like 47 days since we had the last IV infiltrate, or 108 days between CLAPSIs. These are the types of visual displays you can have that will sustain change and continue to build engagement. Create competition, contests between units, or give people rewards. Okay? Maybe when you reach a certain thing, when we went 1 year without having another baby with a sudden unexpected postnatal collapse, we had an ice cream party. Okay, it didn't cost us very much. And the leadership sat there and scooped out the ice cream for the staff. They loved it. Okay, it was a reward for doing a good job and keeping with the protocol and promoting changes. Or you can give them little gifts, things like free tickets to a movie or parking passes to go somewhere. Now, here's another quality improvement project that we did, and this is thanks to Dr. Prudent and Dr. Vane and others who did a lot of the seminal work on delayed cord clamping and made us understand how to do it and how important it was for our babies. So we said, okay, ACOG and the AAP came out with a new recommendation. How are we going to implement this? So we took a quality improvement approach to implementation. We formed a team, okay? We developed strategies together for how to implement this, and we had a very successful implementation. And we published this article. The first author was actually a medical student who did a rotation with me for the summer, and we described how we use quality improvement methodology to implement delayed umbilical cord clamping, and we were able to succeed at having a rate of 75% of babies getting delayed cord clamping in the first year. And by the second year, we were up to about 95% of eligible babies. Okay, there are certain valid reasons why some of the babies weren't eligible, but so highly successful, again, using quality improvement methodology to take us over the finish line. So these were the results. There's a very happy baby there about the delayed cord clamping. 73% in the first year. We had a statistically significant reduction in the proportion of infants who received transfusion from 54% down to 32%. We estimated a cost savings of about $100,000 in the first year due to the reduction in the need for transfusion. Other clinical outcomes we looked at, because you always have to look at things that they in quality improvement call balancing measures. Okay, you want to make sure that you might be improving the one thing you're looking at, but you might be causing a different problem somewhere else. So you always have to look at those measures. And we found no differences in mortality, no difference is in the temperature. We were able to control that problem as soon as we picked it up from that other data I just showed you. And we found a decreased need for respiratory support during the hospitalization. So lots of good things came out of that study. So what was our path forward after that? Monthly reports to look at the outcomes, ongoing education for incoming nursing staff and residents, maintain the current level of effectiveness and support the process as the norm in the delivery room. This is now part of our culture. There's no, I mean, this is just the way we do things now, right? It's been very well accepted. Ultimately, again, I know we had some talk earlier today about some of the issues or conflicts between obstetrics and neonatology. Ultimately, the obstetrician is the one at the table. He or she is the one who makes the decision about when to clamp the cord. But we had a lot of collaboration on this project from our obstetrical colleagues. I have to give them a lot of kudos for that. And we strove for 100%, and we got pretty close. What did we learn? What needs to be changed? Further education and targeted counseling. So I would look each month to see which babies were eligible that didn't get delayed cord clamping. Turned out there was one particular obstetrician that had happened on several babies. So I gave him a phone call. I said, do you have a problem with the process that we put in place about delayed cord clamping? He says, no. He says, I thought I was doing it. I said, okay, well, I have some data that suggests otherwise. And we talked about it, and he was good after that. Okay? So, just, continuous support to the staff to sustain and cement the practice into the culture. Some other things you can do in terms of sustaining change: institutionalize the change by making clinical practice guidelines that are written down or manuals, ongoing education for new residents and fellows, new nurses, staff that turns over. Sometimes you have to re-energize, okay? That's the Energizer Bunny. I don't know if you guys have the Energizer Bunny here, but this is the idea that, you know, again, things sag and people get away from doing things and go back to their old ways. And this is something that's, you know, that you might have to rejuvenate. You might have to figure out a way to get people excited about it again. And don't give up, okay? These were the New York Mets baseball team. They were the team that I rooted for when I was a kid. Because I could actually go see their games. The stadium wasn't too far from my house. And they were the worst team in the league. They were the bottom. For years, they were terrible. And in 1969, they won the World Series. I apologize for the term World Series. I think it's a bad terminology because there are other countries that play baseball besides the United States, but we're too egocentric, so we call it the World Series. But they went from the last place to the first place because they never gave up. And that's part of quality improvement too, I think, sustaining change. Don't give up. So where are we? This is my closing statement to you. In terms of medical quality improvement, I think we're still in our infancy, right? We've learned a lot of things from industry. We're applying those principles, but we still have a long way to go. The methods are rigorous, okay? Some people who are hardcore bench type research people, they don't believe so much in this methodology because it doesn't have a control group and it doesn't follow standard statistics and stuff. But I think I've tried to show you over the day today that we do have really rigorous things, both in terms of how we implement things, the methodologies that we use, and in terms of how we interpret our results. Data management, I showed you just now, that helps to build engagement, right? People can see that timeline. They can see how things are changing. It's great. So I think the mindset in medicine is changing, right? Where I told you earlier in the day, some people used to say, oh, central line infections, we can't prevent those. But now we can. We went recently in my hospital, we went 100 days without having a central line infection anywhere in the hospital. This was a big deal. Okay, you can possibly get to zero. It's hard, but the mindset is changing. Whereas we used to be taught these are complications that just happen and there's nothing we can do about it. They're not preventable. Now people are having a change in their mindset that maybe they are preventable. And some of the drivers for this change are external. Okay, we get evaluated. In the United States, medicine is a highly regulated field now. Okay, we have all these different organizations. We have the Joint Commission. We have a group called Leapfrog. You know of Leapfrog here? So Leapfrog looks at your outcomes, and it gives you a grade. That gives the hospital a grade. You get an A or a B or a C, okay? And then an insurance company can say, well, we're going to use that hospital because they're an A. We're not going to reimburse our patients if they go to the other hospital. They have to go to this hospital. So insurance companies are driving some of this, external agencies, government agencies, all of those things are exerting control over the medical field. Now that sometimes is driving quality improvement. You heard me talk earlier about the fact that we lost money because we delivered a few babies before 39 weeks that we didn't have a hard indication to do. But we lost much more money. We lose much more money if we have a higher readmission rate of patients with congestive heart failure or patients after a myocardial infarction or something. The adult stuff is much worse than the OB or pediatric stuff. A hospital can get penalized 2 or 3% of the money that they get reimbursed for patient care from the government, from the Medicaid and Medicare. And that 2 or 3% to a hospital the size of my hospital is huge. So this is some of what's driving people to improve. They're going to say, you used to say, how can I prevent a patient from being readmitted? Okay. All of a sudden, people now that we were hitting them in their wallet, people were starting to think differently and say, oh, maybe we can do something. Maybe we'll send a nurse out to the house and make sure that the patient is taking their medication. You know, maybe we'll send a nurse out to make sure that that preeclamptic patient is checking her blood pressure on a regular basis, or something like that. There are solutions, and change management and sustaining change are really the trickiest part, because culture is hard. We heard a lot of discussion around culture today. How do we change it? How do we get people to report things? How do we get people engaged in quality improvement efforts? And I do agree that that is a big part of the problem. So Coco looks a little bit better now than he did in the last picture. His tie is a little bit crooked, and Louis is doing his impression of Prince Charles with his hand in his pocket. Okay. He thinks he was the member of the royal family. But again, I cannot thank you all enough, both the people who were the organizers for today and you in general as an audience, because you were very engaged. We stayed awake the whole afternoon, even after eating lunch, and you had important questions and good discussion around these topics. And this doesn't have to be. I wrote adios per hora because this doesn't have to be the end of our relationship, okay? I talked to some people earlier. You know, if there are things that you guys are interested in doing, I'm terrible with bringing business cards because I'm not, like, I don't think about that. So, but I can give people my email. I'm happy to give you my email address, or Nestor has it, Louis has it, and I'd be happy to help you think through a quality improvement project or whatever sort of help you need with getting these things going in your own neonatal intensive care units, because it's so important. We can do better. We've made great strides in neonatology, but we still have a long way to go. So thank you again for a lovely day. I appreciate your time. Okay, whatever you say. You're the boss, Norma.
No, please. Bueno, invito ahora a incorporarse acá al panel reactivo a los componentes de esta mesa. La licenciada Carmen Vargas, ahí está, licenciada en enfermería, enfermera en control de infecciones de las áreas de neonatología y pediatría de la Trinidad de San Isidro. Matías Said y Matías Milber. Matías Said es magíster en Ingeniería en Sistemas de Información de la Universidad Tecnológica Nacional, impulsor de la implementación de la historia clínica electrónica en el Hospital de Alta Complejidad El Cruce, Néstor Carlos Kirchner. Jefe de Trabajos Prácticos de la Asignatura Informática Aplicada a Ciencias de la Salud en el Instituto de Ciencias de la Salud y consultor en Sistemas de Información en Salud del Ministerio de Salud de la Provincia de Buenos Aires. El doctor Matías Milber, médico graduado en la Universidad de Buenos Aires, especialista en clínica médica de la UBA, en CEMIC, diplomado en educación médica en la Universidad Nacional de Tucumán, se desempeña como médico hospitalista desde 1997. Preside el área de seguridad de la atención de los pacientes del CEMIC. Ahora, ¿se escucha? Sí. Bueno, muchas gracias por las disertaciones, fueron realmente hermosas. Y esta última parte nos deja como la tarea para el hogar, y es construir y mantener una cultura de la mejora en la calidad de atención y la seguridad del paciente. Y varias veces se comentó a lo largo de toda la jornada el fundamental e importantísimo rol de enfermería en esto, y coincido plenamente, y bueno, y esa es la idea de que Carmen comparte esta mesa, en que son los pilares fundamentales de la seguridad del paciente y la mejora en la calidad, son nuestras colaboradoras más importantes, son las que están presentes junto al paciente a las 24 horas, nuestra mano derecha, y realmente es muy importante su experiencia en el tema. Y Carmen, tendrás algunas cosas para decir.
Bueno, buenas tardes. Excelente las presentaciones. Mi cabeza quedó totalmente llena de información como para empezar nuevamente, ¿no?, a trabajar con el equipo que trabajo, que es uno de los servicios de neonatología del Dr. Bain. Junto con Adriana estamos y Susana, que son los supervisores. Trabajamos en equipo, nos cuesta porque tenemos todavía algunos inconvenientes, que es mejorar un poco la comunicación, como sabemos es difícil, como lo manifestó allá una de las que representan un hospital, creo, ¿no? Era un hospital público. Y nosotros somos el medio privado y también nos cuesta. Trabajamos también en reducir las infecciones. Yo soy enfermera en control de infecciones. Hago todo lo que es la vigilancia epidemiológica del área, control de catéter, infecciones del torrente sanguíneo relacionadas a los catéter, neumonías asociadas a ventilador, que tuvimos un par el año pasado, y también, bueno, infecciones relacionadas a las sondas vesicales, que eso puedo decir que tenemos 0% de infección ahora. Con respecto a lo que usted decía de la educación in situ, se trabaja y los resultados son los donde más nos cuesta levantar, ¿no?, en el porcentaje de adherencia. Y vamos a tocar un punto simple, que es la higiene de manos, ¿no? Nos cuesta mucho y trabajamos en forma diaria, inclusive hago observaciones sin que nadie lo sepa, como hacemos esas estrategias que tenemos las enfermeras en control de infecciones, de poner carteles, se monitoriza, en este sector se monitoriza la higiene de manos, y por ahí ni miramos la cámara, pero ya la persona, del hecho de ver ese cartel, ya dice, no, me voy a lavar las manos porque me están mirando. Bueno, tratamos de cambiar esa cultura, pero nos cuesta mucho. En relación a lo que usted decía de la plataforma, me quedó ese ejemplo, ¿no?, del transmitir al otro el problema de lo que estamos viviendo. En eso todavía no estamos bien preparados como equipo. Yo transmito las cosas a enfermería, le transmito a Adriana lo que puedo observar de la parte médica, pero bueno, nos cuesta mucho la devolución del cambio. ¿Qué puntos usted considera que tendríamos que trabajar para mejorar esto, ¿no?
Well, first of all, I want to know, do you ever sleep? Because of all the things you told me that you do, I don't know when you have time to sleep. But burning platform, I think it's hard to give a specific answer because it depends on the issue that you're trying to fix. You know, if you can convince people with the data, for example, that there's a direct correlation between them not washing their hands and babies getting the various types of infections that you brought up, then I think, you know, they know when the babies get the infections that they get sick, and some of them actually die from the infections. We had a case recently in the United States at another hospital, another institution, where 9 babies got sick and 3 of them died, and it had to do with contamination of the breast milk. The way it was being stored and what have you, it got contaminated. So I think you have to be, the strategies for the burning platform, they have to be honest. I mean, you can't make something up, but you have to compare what's happening in your unit to other units, or what is out there in the literature, saying we're not doing this the way other people are doing it, we're not getting the best outcomes, it's leading to our babies getting sicker or having more complications, and that's why we really need to do something about this. And eventually, you know, again, you can speak to the nurses very well. I can tell you that nurses are much better about washing their hands than doctors are, at least in most of the studies in the United States. So, you know, you can go out and talk to the nurses, and you can have Dr. Vane talk to the doctors, or, you know, you need to use the people from different specialties within medicine to speak directly to those people and to create that sense of urgency related to the specific problem that you're having in an honest way, but in a way that gets them energized to try to fix the problem.
Matías.
¿Qué tal? Buenas tardes. Gracias por la invitación. Felicitaciones por la exposición, muy interesante. Y me quedé con los dos temas. En lo que es la gestión del cambio, a mí me ha tocado participar de diferentes roles en proyectos de implementación de sistemas, siempre vinculado a veces con calidad, porque obviamente la digitalización no es digitalizar un registro, sino son procesos de trabajo. Y creo que ese es el desafío en los proyectos. Y en esos proyectos a veces es difícil mantener la visión del impacto en todas las variables, por ejemplo, calidad, seguridad, en la gestión de datos. Y una vez estamos por implementar la historia clínica, una en la internación, en el hospital, y no, ya hemos implementado. Y uno de los médicos me dice, ¿sabes lo que pasa con tu historia clínica? Que es una caja negra, meto datos y no me da nada. Y hace poco que estamos en un proyecto de digitalizar todo el hospital, o sea, todo lo que sería los papeles, con firma digital, etcétera, empezamos a hacer un relevamiento de la cantidad de registros que existen locales en cada uno de los servicios. Entonces nos encontramos, si bien sabíamos que estaban, más allá de que está el registro clínico, está el sistema laboratorio, imágenes, etcétera, existe mucho registro local. Entonces la pregunta fue, ¿por qué, hacia nosotros, ¿no?, existe tanto registro local y no existe o no hay la misma calidad de registro en los sistemas? Una de las cuestiones, hipótesis que manejamos nosotros es que a veces los sistemas no los diseñamos para brindar la información que se necesita, y a partir de ahí en los proyectos, en cada implementación, lo que definimos es, se implementa el módulo e inmediatamente se desarrolla algún esquema de gestión de información. La que sea, tenemos un sistema de Business Intelligence, donde se generan aplicaciones, entonces se aplica el sistema y automáticamente se empieza a trabajar en indicadores, lo que la gente quiera. De un indicador para gestión, de producción, seguridad, lo que se necesite, como para que el usuario vea inmediatamente una devolución de la información que va registrando. Y no quede como que meto y sigo registrando mi Excel, mi Access o lo que sea necesario. Entonces ahí tenemos un desafío de poder tener que los sistemas institucionales, por decir una manera, puedan captar toda esa información y generen toda la información para todos los usos. El clínico para la parte administrativa, pero para otro, investigación, seguridad y cosas particulares que puedan surgir como una investigación. Entonces la pregunta es, ¿qué experiencia tienen ustedes en su experiencia, allá en los hospitales que ha trabajado, respecto a esto en la relación de los datos como para medir? Decía la frase, lo que no se puede medir no se puede cambiar. ¿Cómo se gestiona eso? Y si hoy que Estados Unidos está avanzando en toda la digitalización, ¿se tienen en cuenta estos aspectos en los proyectos a la hora de llevarlos adelante? ¿O siguen figurando en paralelo el proyecto institucional y después cada uno con su registro particular?
So thank you for that. I think one of the important things is to involve people very early in your project. Okay, so let the physicians who are going to be using the electronic health record, let them have a voice. And maybe not all the elements that you think are necessary to collect, they may not think that those things are as necessary as you do. Maybe there's some way that you can customize it so that it does become a more useful document for their purposes. And then you can say, okay, guys, we gave you a voice. Okay, we let you have input. Now let's try it and see how it works. And maybe 6 months from now, maybe we have to modify things again. I do think that in order for people, I mean, doctors hate the electronic medical record in the United States. There are numerous studies on this. It takes so much time. It takes them away from the patient. I was never a good typist. Okay, now my skills are a little bit better, but not great. Okay, and if they can't see the value in it, so you have to make a good argument that this information is valuable to them. And the way it's usually valuable is by collecting data that they will find useful. Well, what do you want to know? What information would you like back from filling out the electronic health record? What would the rate of infection be an important thing for you to know? Would you like to know what the length of stay is for your patients as opposed to her patients? Okay, we have a report card actually for obstetricians about different with different metrics that they measure for their outcomes. So looking at rates of C-section, rates of complications, things like that. It's like, when a report card is when you went to school, that's what you got with all your grades on it. So we have that for the obstetricians in our system. So I think the answer is we have to show them the value, but we have to ask them first, what would be valuable to you? How can we make this tool work for you? And then I think you will get more buy-in, more engagement from the physicians. But don't expect them to love the health record, the electronic health record. That's never going to happen.
Hay que confiar más en los millennials y en los centennials. Millennials and centennials will give you the answer. Bueno, muchas gracias por la invitación. Muy buena la charla que me tocó a mí participar. La pregunta tiene que ver con la cultura. Argentina no tiene los mismos. El sistema de salud de Argentina es muy diferente al de muchos otros países, sino al de todos. Y los drivers, algunos de los drivers que mencionaba para el cambio, muchos vienen de afuera, vienen de las acreditadoras, vienen de Leapfrog, vienen de organismos que de alguna manera se fueron metiendo en la forma de financiación de los hospitales, y eso obviamente es un elemento fuerte o que un movilizador que más allá de las palabras lleva a que la gente cambie de actitudes. Argentina no tiene eso porque estamos muy lejos. El camino de la seguridad y por ende de la calidad ni siquiera fue expuesto como en Estados Unidos, que se puso sobre la mesa en el 2000 o en el 99 para que todo el mundo lo viera. Acá se eligió otro camino y entonces se sigue jugando, se sigue haciendo todo el cambio desde puertas adentro, no es algo que está expuesto. Pero muchas de las cosas que pasan en el mundo llegan. Entonces, la primera pregunta, van a ser dos, es que con ese pantallazo general, ¿cuáles son los drivers que dentro de la comunidad de salud, en su experiencia, han sido más efectivos para que la gente entienda de la complejidad del sistema, de la necesidad de trabajar por procesos y de por ende después sí, empezar con las ruedas de mejora, etc. Y ligada con esa es, ¿cuál cree que es el papel de los pacientes? Que aquí también se los tiene todavía muy lejos, pero según yo imagino, van a llegar a impactar en los procesos más pronto que tarde. Creo que inclusive antes de que las acreditadoras puedan hacer su papel como sueñan. Porque los pacientes en realidad sí parece ser algo que une a toda la comunidad de salud del mundo, ya no solamente de Estados Unidos, de Europa, de Chile o de Argentina o de China. Con lo cual, ¿cuál cree usted que es el papel que los pacientes pueden jugar en esto de fomentar o de catalizar el cambio hacia un sistema de más calidad o mayor seguridad?
Well, thank you. So, with regard to patient involvement, we actually have an entire patient safety advisory board. These are people who were patients in the hospital. They may or may not have had an issue, a problem when they were in the hospital, or they had a relative, but they wanted to get involved. And I've actually spoken to them on several occasions about different projects that we've done or we're in the process of doing, and I get their input. We haven't matured yet to a point where we have them involved directly in root cause analysis, for example. There are hospitals in the United States that are already doing that. I think in terms of the medical legal stuff that we talked about a little bit earlier, I think people are still a little bit nervous about having, I mean, the stuff that's discussed at a root cause analysis is at a very high, sophisticated level. And it's hard for me to understand, for example, when a neurosurgeon is explaining to me why something went wrong during a procedure and was this an expected complication or not. If I had no knowledge of medicine whatsoever and I was sitting there listening to that conversation, I might not understand it in the proper way. So I think that's the hesitancy. I hope that we can mature to a point where we will have patients directly involved in that. But we do have them involved in patient safety in an important role, but a little bit less direct. Okay. The first question you asked was, what are the most important things in...
No, ¿qué drivers, qué drivers podrían encontrarse por fuera de lo que es la demanda externa de un acreditador y para impulsar el cambio, en tanto en cuanto el cambio dependa de la propia comunidad de salud y no tanto de la parte externa, digo, pública, gobierno, acreditadores, etcétera?
Well, I think the motivation is something that's internal, and that I think people in medicine want their patients to have a good outcome, and they want the very best for their patients every day. So if you can motivate them by showing that there are things that we can do differently that would improve the outcome for the patient, I think that would help as an internal driver. I think most of us have that internal driver, as people who went into medicine, but I think we need to change our mindset a little bit. And people like you who are involved in patient safety and are getting more involved in it and getting more education in it and educating other people within your system about patient safety. I mean, we have lots of programs that nurses and doctors and other people in our system. We have a lot of people who have green belts and black belts in Lean Six Sigma within our system. We have probably over 100 people, and each of them did a project to get that certification. They each probably had 10 or more people involved with them on the project. So it just has to grow naturally, sort of organically. Within your system, it's slow changing, but you have to be a leader, and a leader is the one who stands in the front and helps pull the wagon, right? Everybody together. Not a leader is not somebody who sits in the back and goes, pull the wagon. You're out in front helping them, and that's what people like you are going to do as you get more involved and generating change here in terms of the attitudes towards quality improvement.
¿Alguna pregunta en el auditorio? ¿Alguien que quiera hacer algún comentario? Sí.
Gracias. ¿Qué tal? Mi pregunta estaba dirigida directamente a medir el clima de seguridad. No sé si se puede hacer, una forma de intervenir, se habló de intervenciones en cuanto al clima de seguridad a partir de capacitaciones, pero evaluar y medir el clima de seguridad es muy difícil, lo hacen, hay score, hay encuestas, o todo viene armado dentro del mismo paquete y a partir de la medición de los eventos adversos o trigger tools se plantean estrategias de intervención para modificarlas.
Yeah, so, the type of data you're talking about related to quality improvement metrics, that's something that you have to have a robust system through your IT people to be able to generate that kind of data. But there are culture of safety surveys. Our hospital does one every 2 years. We got a 70% participation rate the last time we did it, which was 2019. It's a fairly comprehensive survey that goes to everybody who works within the hospital system, assessing their attitudes towards patient safety. And it's put together, it's a pre-designed package survey. It's not something we developed ourselves. That was produced by Press Ganey. Is that an organization that you guys are familiar with at all, Press Ganey? They do a lot of the surveys that patients get once they go home from the hospital. They get a survey to fill out that says what their experience was like. In the United States, that's a very common thing for hospitals to be able to judge how well they're doing with the patients. They also have developed this culture of safety survey. I have no idea what the cost is to purchase this product, so I'm not advocating for it, but it's very important questions about what do you think about communication within your unit? What do you think about the communication between your unit and another unit? What do you think that the management values patient safety? Is it a high priority for the organization? I mean, there's a lot of different types of questions that we look at, and we learn from it. For example, the last time we did it, we scored very well for communication within units, but we didn't score very well for communication between units. So now we're working on developing strategies to try to improve that type of communication. So that's the only way that I know of that is a sort of a tool that exists to have a system-wide look at your culture of safety.
¿Alguna otra pregunta? Sí.
Aquí en la Argentina hay para validado un instrumento en la Academia Nacional de Medicina, que lo validó creo la doctora Sumortiz. Es decir, nosotros lo aplicamos 2 o 3 veces en el hospital y daba bastante, los resultados eran bastante racionales con lo que nosotros esperábamos y está validado para Argentina.
¿Alguna otra pregunta? ¿Allá? ¿Sí? Adri.
Yo quería preguntarle, sabemos que la seguridad se trabaja en asociación con las familias. Yo quisiera preguntarle cómo trabajan esto con las familias en la unidad neonatal y si es que esto lo han extendido a la internación conjunta con recién nacidos sanos, ¿no? Donde uno tiene que hacer tanto educación. Quisiera saber cuál es el trabajo con las familias.
So I'll just give maybe one example because the hour is getting late and this is the only thing standing between you and a long weekend. So I'm trying to be respectful of that. But one of the ways that we involve families is that our system for reporting a problem is available to anybody. And the families can put in a concern about something that happened to their baby into our system, and then it gets reviewed by me and the chairman of the department and the head of neonatology and all these different, and the nurses, the nursing managers, to try to address their concerns. We also have family-centered rounds, so when we make rounds on the patient and discuss the details of the patient's condition and what the plans are for that particular day, the families are there with us on the rounds. They hear everything directly from the team that's in charge and responsible for the care of the baby. Patient-centered rounds. So those are 2 examples of how we involve the families.
Adri. La misma. Una última o pequeña reflexión de todo lo que escuchamos. Comentábamos que el sistema médico argentino, el sistema de salud argentino es muy particular, muy diverso, no hay por ahí las motivaciones como pueden existir en otros lugares. Entonces preguntaban cuál era el mejor movilizador para embanderarnos en esto de la mejora en la calidad de la atención y la seguridad del paciente. Y mi reflexión fue que cuanto más difícil es el entorno que nos rodea, cuanto más difícil es el momento, cuanto más difícil está el lugar en que trabajamos, o sea, cuanto más negativas son las circunstancias que nos rodean, creo que más necesidad tenemos de gratificarnos con lo que hacemos, de sentir que lo que hacemos es bueno, que nos sale bien, que lo podemos mejorar. Son pequeñas compensaciones, grandes compensaciones, pero creo que no hay nada mejor en medio de las múltiples dificultades que tiene nuestro país y nuestros lugares de trabajo, es sentir que lo que hacemos lo hacemos bien y que lo queremos hacer mejor, porque eso es quizá lo único que realmente podemos hacer cada uno de nosotros. Muchas gracias.
Bueno, muchas gracias a todos. La verdad que ha sido un día muy fructífero, muy intenso. Hemos estado acá desde la mañana. La idea original, cuando charlando con Stephen y Coco, fue hacer esta reunión, fue esto: hacer un grupo chico, que hubiera mucho intercambio, invitar gente de distintas características, no neonatólogos, hemos traído especialistas de todo tipo, enfermeras, tecnología de la información, clínicos, y bueno, estuvieron las autoridades de salud pública. Y debo decir que con Coco comentábamos lo importante, tuvimos a Ana Esperanza y a Diana Fariña, que con la excepción de un año y medio, desde el año 2004, mantienen la continuidad de los criterios en salud pública, en salud materno infantil, lo cual es poco probable que ocurra en otras especialidades. Y hemos tenido el placer de escucharlas y de ver el entusiasmo y la motivación que tienen, y esperemos que el futuro brinde gente de las características de ellas que permita continuar con esto. Y por otra parte también le queremos agradecer a Norma, que se puso la jornada al hombro. Nosotros, Coco y yo, tuvimos la idea, pero después trabajo nada, y Norma hizo todo, y por eso salió bien. Así que, bueno, sí, la realidad es esa. Así que, bueno, Coco.
No, yo también coincido con todo lo que dice Luis y quiero agradecerle particularmente, además de Norma, a una persona sin la cual no podemos organizar ninguna jornada, no estamos dispuestos ni Luis ni yo a organizar nada. Yo creo que no la voy a convocar para organizar una cena o algo parecido, pero para el resto nosotros no podemos trabajar sin Susana Ibáñez, es de una eficiencia alucinante. Y también le quiero agradecer a Oscar y a Ariel, que se han ocupado de que esto no solamente se escuche aquí, sino que se pueda seguir desde cualquier parte por internet. Y también, por supuesto, a Ana Mastronardi y su equipo, que nos han siempre apoyado con su traducción, su capacidad de traducir todo. Yo siempre digo, ahora lo digo públicamente, que uno sabe que están traduciendo bien y rápido porque cuando alguien hace un chiste se ríen al mismo tiempo que la persona lo hace en inglés, los que están escuchando con la traducción. Y eso habla mucho de la calidad. Y Luis y yo estamos impactados todavía del lugar que nos han permitido hacer esta jornada, del Espacio Aguaribay, que con una generosidad total nos dejaron usar este auditorio para el número de personas que estábamos, que coincido con Luis que es el ideal para este tipo de reunión, no podría haber sido mejor. Confieso que esta mañana cuando llegué me asusté, le dije a Susana Ibáñez, porque acá en la puerta estaban perforando la calle. Y me dice, ¿cómo están perforando la calle? No se escucha nada. Esto es un estudio de grabación de sonido, con lo cual lo que pasa afuera ni nos enteramos. Así que nuevamente a todos los oradores y los paneles reactivos y todos los que estuvieron sentados en el público pero participaron también, les agradecemos mucho, y especialmente a Stephen, que lo hemos gastado como gastamos a cada uno de los invitados extranjeros que traemos para nuestras jornadas. Muchas gracias.